Welcome to the World Webinar on Cataract and Refractive Surgery. Almost 100 speakers from across the globe. WWCRS 2021 is the first of its kind. For 16 sessions in this 2-day extravaganza, the entire ophthalmic community bringing together the best of the best to keep you up to date with ideas from all around the world. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India. WWCRS 2021. Global names directly to your home starts now.
Here you are again, the day 2 of this big event. Today is the big day. Today you have Film Festival and Virtual Light Surgery. Actually, what you want to say for everybody, my friend?
Thank you, everybody. Thank you, Sergio. Thank you, speakers. Thank you, sponsors and audience. Without you, there is no program. So thank you so much for coming back. I want to give you, at the onset, Sergio spoke about it, but I'm going to tell you a little bit more. We have the Film Festival Award Show today. All 90 films have been loaded on World WCRS website. We also have the virtual live surgery event. Don't miss that. There's just a couple of instructions which I want to give everybody, because if they were not here on the first day of the event, that was May 29th, I want to tell you that there is a chat window on the right corner of your screen. Use that to put in your questions during the session. It is a very fast-paced event. And the second, your poll questions, the moderators will be putting them up right in that same chat window, so don't miss the opportunity of clicking in. If you're watching this on YouTube, please come to the World WCRS website, because that's where you will be able to use the chat window for poll questions and asking your questions. So let's move with the program, because I know you guys are eager and ready to go.
CSL in Challenging Ectasia Cases session. The moderators: Renato Ambrosio Jr., Brazil, and Farhad Hafezi, Switzerland. We welcome the panelists: Andres Benatti, Argentina. And featuring the speakers: Renato Ambrosio Jr., Brazil, Farhad Hafezi, Switzerland, Cosimo Mazzotta, Italy, and Bradley Randleman, USA. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
So good morning, good afternoon, everyone. We are here to start this great session, and I'm very happy to be here with my colleagues and friends, Dr. Farhad Hafezi, Cosimo Mazzotta, Andreas Benatti, and Fred Redeman will come as a virtual speaker with his great video and his great talk. So we start with a poll, and the poll should be: what is the ideal method for detecting ectasia progression? So should we put the poll on the screen, please?
I'm sorry, just 1 second. We have technical issues and...
Okay, no problem. So
allow me 1 moment, please.
That's what I thought, because I didn't see any switch to one of us.
Yeah, we're working on it. I'm so sorry about that. We're just
no
fixing
problem.
it.
No problem.
So I will let you know.
You do the... Okay.
I will let you know whenever you can start the introduction, okay?
Okay.
You want to do the introduction, Renato,
please.
and then I'll
I
read the
just-
poll?
Good evening, wherever you are in the world. We are very happy to be here with my friend Cosimo Mazzotta, Andreas Benatti, and Farhar Hafezi, to whom I pass the bar for starting this great session with the poll. Farhad, please.
Hi, Renato. Hi, everybody. See, did it switch? Right. I hope everybody can hear me. Let's start with the poll. What is the ideal method to detect ectasia progression? Is it A, distance-corrected vision, B, front surface topography, C, 3D tomography, D, ocular wavefront, or finally E, corneal biomechanics? And please take your choice, and then we will start the discussion after the talks with these with this poll. And it's my pleasure to introduce the first talk, which is given by Renato, CXL for KC in the first consultation, when and why.
Thank you very much, Farhad. And it's a pleasure to participate. And this is a question that we all face in our daily practices doing our consultations when you see patients with corneal ectasia and keratoconus. These are my financial disclosures. I also acknowledge my collaboration with the BRAIN, the Brazilian Artificial Intelligence Networking in Medicine. I start with a quote that, as we know, we have to be humble and always willing to learn more. That's how I interpret this great wisdom from Socrates. And when we think about diagnosis for ectasia, we have to distinguish screening for refractive surgery candidates and managing patients with ectasia, ectasia susceptibility, diagnosing ectasia, staging the disease, prognosis, which is critical in this question of this talk, and eventually clinical management will be based in a more solid understanding based also in the follow-up. And we have to use multimodal imaging, and we have to understand what we have in terms of tools for imaging, and also what we have to answer in terms of questions as we described. We have multimodal imaging, for example, with the pentacam, with axial lens and ocular wavefront, different application of diagnosis for many situations. I can go closure glaucoma and ectasia, of course. And ectasia can have the diagnosis and also the follow-up with the ABCD from Michael Belli. Interestingly, the paradox is when to indicate surgery for corneal ectasia, because the need for surgery is related, in my opinion, to ectasia progression or very high risk for ectasia progression or inadequate vision when glasses and contact lenses are failing to have the patients to return to good vision for visual daily tasks. And if surgery is needed, it should be done as soon as possible. But if not indicated, should not be done. That's why the paradox. And we come with a very nice paper that was the consultation section of the JCRS in March this year. We had a scar after cross-linking in a patient that had, we don't have the pre-op of this patient, the pre-cross-linking, but we have the scarring and 2025 with some irregularities that the patient is being bothered by, and the fellow eye is a very almost plain, or I would say perfect quality vision that I had. And I was able to look at the pre-op at the current status of the right eye, and there's no ectasia. But at 32 years old, I would say that the best thing, even though cross-linking is a Nobel Award deserving achievement for the development of the cross-linking, the great group by Theo Seiler and all the leading group from Dresden and Hafezi and Michael Mrohen from the work in Zurich, they deserve a Nobel Award for that. But we should think about the wisdom that prevention is better than cure, and preventing progression of ectasia should be balanced with the risk for inducing irregularities like in this case. And like we have in our Valigen campaign, patients should understand that. And eventually, we know that not every eye that's being rubbed will have ectasia, but eye rubbing is 100% of agreement in the global consensus that it aggravates the disease. And I would even go ahead and say that it aggravates keratoconus and causes ectasia. So the 17 years old comes with 2040 uncorrected, 2025 corrected in the right eye, has a very mild changes that can be detected in tomography biomechanical integration. And we decided to treat the allergy, and the follow-up 3 months later, this is a very recent case, he improved vision. Even though he had some mild irregularity, you see some flattening in both topography from Placido and the shine forgiveness. So this patient, we believe that oral B2 allergy control can be enough for this case. And of course, follow-up and education is a must. And you can see that even in the Bellin ABCD display. Interestingly, another situation, also a patient that came very recently, 22 years old, and you see some more weakening in the biomechanical factors, and this patient has need for surgery unquestionable because he's saying that his vision is getting worse over the last year. And we confirmed from fluid keratoconus in the left eye, and the need for follow-up is careful. This is the wavefront that can help you, even though giving some vision we have to be follow this patient in the left eye, but surgery should be indicated in the right eye. So when we manage corneal ectasia, we have the paradigms broken, paradox created. The concept of integrating artificial intelligence and ancient intelligence, which is philosophy, should be applied in individualized medicine. Humanized medicine, patient education is a critical factor because we have to understand that we should always comfort the patient and the family, especially in patients with keratoconus, that in young age, they have the diagnosis and a lot of confusion that can come from all this misunderstanding and lack of information. So thank you very much for your kind attention, and I look forward to great discussion. And with not further ado, I pass to Farah Hafezi for introducing the next talk.
Hafez, you are muted.
Thank you very much. I was muted. Okay, so let me just very briefly go back. I can't go back, but that doesn't matter. The topic is CXL in ultra-thin corneas, as you have seen before. And the question is, looking at this OCT scan, can we cross-link a cornea that is barely more than 215 microns at the thinnest stromal point? And the answer is yes. Let's have a look at the history behind it. So initially we had the Dresden protocol for 400 micron, and then the first method that had been established to overcome the 400 micrometer rule was the swelling of the cornea that we introduced in our Zurich group back in 2009. Then a few years later, Susan Jacob had the idea of putting a contact lens onto the eye. That's contact lens assisted cross-linking. Now, if you ask me if I perform any of these methods today to treat very thin corneas, the answer is no. Why? Because either of these methods has major drawbacks. Let's look at them. If we look at the swelling of the cornea, the one we introduced, the biomechanical effect is quite good. Similar to the unswollen cornea, Wollensak has shown this again 2 years ago, but the whole swelling is totally unpredictable. Some corneas swell a lot, others do not. So you never know what is going to happen before you switch the UV light on. And as surgeons, we don't like surprises. And I don't like to do contact lens assisted cross-linking because no matter which contact lens you use, you will always have a relative lack of oxygen. We already published on this 6 years ago and Wollensak again 2 years ago, 30% less efficacy. So let's take this together. What have we done until now? Until now, we have used methods to swell the cornea if the cornea was too thin. So, to increase thickness, either we swell it or we put on a contact lens. So in other words, we adapted the cornea to the CXL technology. Now, what we propose the future will be is the exact opposite. Instead of adapting the tissue to our technology, we should adapt our technology to the tissue, right? That makes much more sense. What does that mean? It means that we individualize the approach and use the right total energy for every thickness that presents in our practice, and not just one fits all. How did we do this? Well, 3 steps. In the first step, we had to develop the algorithm. We did this 6 years ago and published this back in 2017. Then, second step, we had to develop the protocol, and it's fairly straightforward. You do an epi-off abrasion, you apply riboflavin 10 or 20 minutes, depending on the riboflavin. Then, before you switch on the light, you measure thickness. And with that value, you adapt the fluence. And how do you do this? Adapting the fluence, we did in the third step a clinical study that was published a few weeks ago. To adapt the fluence, we have taken the original Dresden protocol, and as you can see here all the way down, you see 400, that's almost 30 minutes. And then the thinner you go, the less minutes you need to reach a demarcation line at the desired depth. So if you do the epi-off, you give the riboflavin, then you measure by ultrasound, and your cornea is, let's say, 280 microns of stroma, you need 5 minutes at 3 milliwatts to hit a demarcation line of 210 microns. We could have developed this whole protocol using 9 or 18 milliwatts too. Then the relatively thicker corneas would have been treated faster, but we deliberately chose 3 milliwatts. Why? Because we wanted to open the access to all users globally, and no matter who's doing cross-linking, they at least have an old 3 milliwatt machine. So democratizing access. The study itself was performed with a 1-year follow-up and showed a surprisingly high success rate of almost 90%. The thinnest treatment was in a 214 micron stroma cornea. And we also saw a flattening that is in line with previously published studies in thicker corneas. As I said, you can use any cross-linking technology to do this. In the case of cross-linking at the slit lamp that I co-developed, here the whole protocol is integrated into the machine for convenience. So in conclusion, the future in ultra-thin corneas is individualizing the fluence, the sub-400 protocol. Treatments down to 200 microns of stroma are possible, and these treatments can be performed with any cross-linking device. Thank you for your attention.
Thank you very much, Farhad. Great contribution. We look forward also to have the 9 milliwatts, because some people would like at the university where we have a center for keratoconus referral, we only have the IROC 2, which is standardized for 9 milliwatts. So we need your science to keep evolving, and thank you very much for the great work. So now it's a pleasure to introduce Dr. Cosimo Mazzotta, who is going to talk to us about in young allergic eye rubber children, how to do cross-linking. Cosimo, please.
Good morning. Thank you for the invitation, and I congratulate with the organizers. We speak about cross-linking in very young allergic eye rubber children. It was a correlation between allergy and keratoconus, and it was described, first reported by Hilgartner in 1937. There is a correlation, of course, between inflammation and keratoconus because we have a lot of clinical evidence and also instrumental evidence that keratoconus cannot be defined only as a degenerative disorder or a non-inflammatory disorder, and that in the pathogenesis of this disease, progression may involve chronic inflammatory events. A lot of evidence in literature of inflammatory processes correlating with keratoconus development and progression are reported in contact lens wearers, atopic patients, allergic patients, vernal keratoconjunctivitis patients, rosacea patients, and eye rubbers. And also a lot of evidence in patients with tear film dysfunction correlated with keratoconus faster progression. Interesting review from Robert Weiss and Cole showed that we have an increased metalloproteinases levels in the tear fluids, in the increase of cytokines, and in particular interleukin-1 with pro-inflammatory effect and pro-apoptotic effect on keratocytes, and also inducing a myofibroblast transformation of keratocytes. So in these particular patients with the genetic susceptibility, the specific environmental factor of the corneal surface with the rubber and the increase of the expression of concentration of soluble immune mediators increase and stimulate keratocyte apoptosis and the differentiation of keratocyte in myofibroblasts. Overall biomechanical and biochemical modifications stimulated with process of modification of the extracellular matrix and the stromal remodeling affecting collagen distributions, leakage, and volume depletion with the particular typical thinning of keratoconic disease. We have published the work on keratoconus progression in patients with allergy and elevated surface matrix metalloproteinases 9 that was tested with the inflammatory 9 point of care test. And this study showed that maximum increase of Kmax was correlated with the highest hypertrophic papillaris tarsal response that were particularly higher in keratoconic allergic patients compared with non-allergic patients. So the association between pediatric age, allergies, and eye rubbing may represent a dangerous situation stimulating faster progression of the disease. And this was confirmed recently in an interesting nationwide epidemiological study concluding that it is important that the severity of allergy is correlated directly with keratoconus progression. And atopy and allergy provokes eye rubbing and local irritation, resulting in a mechanical and a biochemical damage of the corneal surface. Even though there is an association, not necessarily imply a causality or a causative association, this is, of course, very important pathogenesis of progression of the disease. And I have also demonstrated this in the long-term results, the 10 years results of corneal cross-linking in pediatric patients, where only the 4% were retreated. And among these young patients, all the retreated patients belong to the allergic. So the higher aggressiveness and progressiveness of keratoconus in pediatric patients having allergy and atopy are very higher compared with other patients. Actually, we can do 9 milliwatt corneal cross-linking for progressive keratoconus also in pediatrics, as shown by the Siena ICROS study 2, that this was recently published in Eye and Vision, together with Professor Afesi and Frederick Leiscook from the Dresden School. And we showed that 9 milliwatt accelerated cross-linking was safe and efficacious in the long-term follow-up of over 5 years, both in young adults and in pediatric patients in the long term. So, in conclusion, we highlight the higher potentiality of ectasia progression in pediatric patients suffering from allergy and eye rubbing by providing appropriate screening and improved care of atopy And another stressed importance of choosing eye rubbing to do close monitoring to this situation and alert pediatricians and ophthalmologists for early keratoconus screening, doing cross-linking without awaiting progression in your young allergic eye rubber children. Thank you for your kind attention. Good morning, thank you for the invitation, and I congratulate with the organizers. We speak about cross-linking in very young allergic eye rubber children. It was a correlation between allergy and keratoconus, and it was described, first reported by Hilgartner in 1937. There is a correlation of...
Thank you.
Okay, now finally, good. So let's continue with the last talk, which is given by Brady Wendelman, and it's about cross-linking in post-operative ectasia. Brad? I think that due to some repeat of the previous talk, it might take a second. It should come up now.
Hello, thank you for giving me the opportunity to speak today. I'm Brad Randleman, coming to you from the Cleveland Clinic Cole Eye Institute in Cleveland, Ohio, and I'll be speaking on corneal cross-linking in post-operative ectasias. I have no financial interests related to this topic. I do, however, have two textbooks written alongside Farhad Hafezi, and Farhad and I also have a review article published in Survey of Ophthalmology on this topic. Corneal cross-linking has been with us for almost 2 decades. It was first evaluated in patients with progressive keratoconus by Wallensack, Sporl, and Seiler. Professor Hafezi's group published long-term outcomes looking at cross-linking results for patients with post-operative ectasias and found this to be a successful treatment in these patients. Cross-linking has been approved in the United States, both for patients with progressive keratoconus and for patients with corneal ectasia after refractive surgery. Both of these trials were done using the standard or Dresden protocol. And the primary endpoints looked at were the change in Kmax in treated versus untreated, and the change in corrected acuity. And we know from this data that the standard protocol is effective for treating both patients with keratoconus and those with postoperative ectasias. There is greater variability in outcomes when you look at patients who have had postoperative ectasias. However, the treatment modality is successful for the vast majority of individuals in both of these groups. A variety of cross-linking protocol modifications have been considered, and we will look into 3 of these briefly. There have been a variety of accelerated protocol techniques evaluated. When looking at laboratory data using both destructive mechanical stress strain testing and non-invasive Brulon imaging, there is a significant reduction in corneal stiffening induced with any acceleration beyond the standard or Dresden protocol. However, the clinical significance of this remains to be determined. We looked at 3 different cohorts using 3 different protocols, and these were for patients with keratoconus, not postoperative ectasia. However, when we looked at these groups, we found no difference in the primary endpoints evaluated. So there were no differences in the change of Kmax between protocols, no difference in the change in corrected acuity. There was an advantage in corneal regularization as measured by a change in the asymmetry indices for the standard protocol. But this was the only difference we found. It is therefore possible that there are no major differences between these protocols, it is also possible, and I think most clinicians would acknowledge that looking only at a change in corrected acuity or change in Kmax is a very limited way to evaluate the efficacy of cross-linking protocols. A second modification specifically for patients with postoperative ectasias that has been put forward is a novel cross-linking technique whereby the flap, the LASIK flap, is reflected and the cross-linking is done essentially within the body of the cornea. The concept being that you can get a deeper treatment and perhaps a more robust treatment by doing this. We evaluated this recently in the laboratory, again using Berlin microscopy, and what we found is when you look at the anterior third of the cornea, where the vast majority of cross-linking occurs, the standard protocol induced significantly greater stiffening than the flap lift technique. There were really no differences in the middle or posterior portions of the cornea, which is expected because most of the cross-linking occurs in the anterior cornea, as we know. These results were confirmed by mechanical testing as well. The final topic we'll touch on is prophylactic cross-linking at the time of LASIK. There are numerous studies published to date, but the literature is quite divided on the efficacy of this technique. Again, we looked at this in the laboratory a few years ago and really found that the rapid or accelerated cross-linking did not impart any significant stiffening impact after the LASIK flap was created. So to summarize here, standard cross-linking is safe and effective for postoperative ectasia. There's slightly greater variability in outcomes than what we've seen for cross-linking in progressive keratoconus. Nevertheless, this is a great technique and something you should be utilizing in your postoperative ectasia patients. Any modifications of the standard protocol are less well studied and less well understood. Accelerated protocols to date have undetermined relative efficacy to the standard protocol. Flap lift cross-linking, at least in the laboratory, appears less effective than the standard protocol for postoperative ectasias. And the jury is still out on whether or not prophylactic cross-linking has any real biomechanical impact for LASIK or other techniques such as surface ablation or SMILE. So thank you very much for your attention. I'd like to thank all of my co-authors and workers in our lab for help making this data possible. And thank you very much for your attention.
Thank you very much, Farhad. It was Brad. It was a great talk, and fortunately, you're not here with us for the discussion. So I'll start with the discussion with the results for the poll. And the question was, what's the ideal method for detecting ectasia progression? And when we decided to do this question, I think ideal method is the kind of a picky word. Maybe the current best method will be a better terminology for enhancing the discussion. I decided to put ideal method because in the future, ideal methods will be biomechanics or even genetics. But the current best method is tomography, in my opinion. We have some people that still have to use distance corrected vision because it's kind of a late way of detecting ectasia progression because it's a very late change of the cornea. The cornea would have progression of ectasia, and then you have this vision correction. Topography is kind of in between, but you have a tomography evaluation of back of the cornea, and the thickness profile can enhance your ability to see progression. And ocular wavefront is also very important for us to understand how the patient is having in terms of visual acuity, visual performance, but it's not the best way of looking at ectasia progression, but actually it's something that is all integrated. So we cannot give up any of this information, the clinical daily practice, but the correct answer will be, in my opinion, tomography to three-dimensional reconstruction. Eventually, epithelial thickness can even further improve this. So this is the poll of the questions. We appreciate all the answers, and I give the word to my colleague and friend, Dr. Hafezi, who will come with nice discussions about this great talks that we had. Thank you.
Thank you very much, Renato. Just a brief mention now that we have seen the poll, maybe regarding eye rubbing and Cosimo Mazzotta's talk. We have new data that is being submitted now where we used our eye rubbing machine to perform thousands of rubs repeatedly within short term, and we didn't see any change in biomechanics. And what this showed to us is that, as Cosimo has mentioned, I believe that it is the secondary inflammatory long-term responses that are more harmful to the cornea than the immediate effect of the mechanical rubbing. So I'm a little more relaxed when I see the patient in front of me doing 3 times this, because he has to do it repeatedly. And so the question is, how, Cosimo, how do we prevent the allergy-related inflammatory signs in children, which might be at the root of the problem? So allergy in inflammation and then eye rubbing because of itchiness. How do you do this in your practice? And later on, maybe Andres or Sergio can give us insights on how they handle it in their respective practices.
Okay, thank you for your question, because we have a multifactorial genesis of the progression. So we cannot give the patent of progression only to eye rubbing, to a mechanical situation, but of course we have first a genetic susceptibility and a lot of release of inflammatory factors on the ocular surface from conjunctiva and corneal epithelium. So first of all, in the anamnesis of this patient, we need to know if patients are allergic, are atopic patients, or suffering from alteration of ocular surface or general allergic or atopic diseases. Then we need to manage carefully the ocular inflammation, also blepharitis, also before doing cross-linking, because we have a lot of inflammation also in the post-operative and the higher risk of AIDS in this patient after epithelium of cross-linking. So these patients suffering from ocular surface inflammation must be managed very carefully also to prevent complications, not only the progression of the disease. So I manage this with antihistaminic drugs, with steroids if necessary, and also with immunosuppressive like cyclosporin A and tacrolimus. So we have a lot of pharmacological approach and also lifestyle approach. And we need also to collaborate with general medicine and allergology and pediatricians of these patients in a multidisciplinary collaboration to have a good outcome of these cases.
Sorry, guys, I would like to mention something that I think is very important for our audience. In a pediatric, as you guys said before, in a pediatric patient, it's so important the patient education, and we don't have to wait progression. We know that in this kind of patient, the keratoconus is more aggressive, and we have to do something now, today. And that's why the cross-linking therapy is so important. And I would like to ask you, to all of you, which is the youngest patient that you treat with cross-linking, if you have seen something different in the post-op follow-up, like a trouble with the epithelialization or some kind of case. What do you guys think about?
I have treated a 4-year-old patient with cross-linking. Wow. And the patient behaved beautifully. Actually, the little guy came in the OR with his mother, and he lay down on the bed for the. We do that in the laser suite, and he did perfectly well. And the next patient was an old guy that was going to do LASIK, and it was a nightmare. So this is possible for doing it without any type of general anesthesia, just talking to the patient gently and everything. And I know Hafezi has a long experience with even challenging cases like Down syndrome and things like that, but this great work that he's doing. So this is great. This is great to do. When to do it should be done as soon as possible.
Agree, 100%.
Cosimo, any tips for us to enhance the wound healing response after cross-linking in very allergic patients? How you manage that? Because those patients can have epithelial defects for a longer time and having more trouble for healing. Any tips for finalizing this? Great discussion.
Thank you, Renato, for your question, because it allows to me to precise that I have noticed an effect of desensibilization after cross-linking. A lot of these patients experienced after cross-linking less photophobia, less eye rubbing, less itching, less eye redness. So I think that maybe cross-linking may have a good indication also in reducing sensibility of the ocular surface.
Mm-hmm.
Do you have this experience also in your patients?
Exactly.
Yeah, same experience.
Exactly.
No, please.
We love it.
It could be another.
I have a question from the audience.
Well, we are.
See, do we have any questions?
We are coming to the closing of the session. And if we can summarize the session in a couple words, I would say customizing, individualizing, enhancing the management for patients with ectasia. So thank you very much for Sergio Canabrava and Ashley Nagaval for organizing this great webinar of cataract and refractive surgery. And I give the last word to my fellow friend, Hafezi, for finalizing this great session. Thank you all for the attendance and for the great talks.
Dear all, it was great to see you. Thanks again to Ashwin and Sergio, and hopefully see you physically sometime in the near future. Bye-bye.
Thanks, guys.
Thank you.
See you.
Thank you. Take care. Let me wait. Let me take one screenshot. Okay, I got you all. Okay.
Before the surgery, I had to use bright lights. After the surgery, I could see things clearly in low light. It made a great change in life. It's a great feeling. Oh my God, if you use glasses and then if someone says, you don't have to use anymore, that's a great thing.
A mí me dicen que voy a ver bien y digo, vale, pero no me lo imagino. Yo me asombré, encantada.
My vision is excellent. Even in areas where I had to wear glasses before, I never thought my vision would be so good at age 81.
La noche y el día, parece que acababas de nacer, de esa visión tan sumamente clara. No es que mejoró, es que se transformó totalmente.
Oh, it was unbelievable. I could see everything from distance to up close with no issues. I have no difficulty driving at night anymore.
Ya la vez de nuevo fue maravilloso. Me doy cuenta que hago cosas que antes no hacía. Es difícil de explicar, pero es una sensación de alegría. Mi sentimiento fue de alegría.
They've changed my life. I was just absolutely astounded. I can see everything. I can do anything I want to do.
Todo lo que antes no podía, ahora ya lo puedo realizar. Veo bien.
I would rate it 10 out of 10 in all conditions, whether it be night or day. Everything's so much clearer. Even when you're surfing there, you can see a little fish swimming around. It's just amazing. That's something you couldn't believe could happen to you at my age. It's just life-changing.
Recent advances in glaucoma session. The moderators, Interpol Sign, USA, and Lukan Mishev, Bulgaria. We welcome the panelists. Ahmed El Masri, Egypt. And featuring the speakers, Priya Narang, India. Leon O, UK. Akashihara, Japan. Then Artur Huni, Brazil. Organizers: Sérgio Canabrava, Brazil, and Ashwin Agarwal, India.
Hey everybody, thank you so much for joining us. I'm Paul Singh from the Eye Center here in Wisconsin, and here with Lucan from Bulgaria. What's up, Lucan? How are you?
Hi, Paul. Hi, everybody, and welcome to this hopefully wonderful session. Hi from Bulgaria. Let's see what we're going to do now.
Yeah, first of all, we want to thank all of our panelists and our presenters we have from around the world. Looking forward to all the great presentations. But before we start, we wanted to make sure we have a poll that we have to start out with, just to kind of get an idea of where everyone's at here. So let's see if we can get that poll up and running as soon as here. We should have that coming up. But in the meantime, while we're getting the poll up and running, and before we get our presentation started, Luke, I'd love to hear your thoughts. In your philosophy of glaucoma, what has changed in terms of mentally? When is your trigger to perform surgical options or interventions? Has that changed in the last few years?
Actually, a lot, because as we know, the MIGS devices are around for probably 10 years already, and a lot of experience is already gathered. And we have a bunch of less invasive maneuvers which can facilitate our approach. And it is not only a trabeculectomy or drops. There is a zone in the middle on which we can intervene a lot. And now actually with introduction of a slow release devices, Durista, etc., we have even more in our armamentarium. So my trigger for invasive treatment is even lower now because we have a lot of options.
Absolutely. Our toolbox is expanding. And I want to just start out with a poll here. We have a polling questions here for the audience. Love to get your thoughts. And kind of to your point, kind of what is our trigger and what is our choice for surgical options? So the question is, what is your choice for primary surgical anti-glaucoma intervention in a progressing moderate open-angle glaucoma patient with target IOP in the middle teens, but not tolerating topical medication? So moderate glaucoma progressing on topical medications. So you have a trabeculectomy / express tube type of surgery, MIGS, various conventional pathway MIGS, photocoagulation, cyclophotocoagulation, PDS or non-penetrating deep sclerectomy, CLASP procedure, PreserFlow or Zen. So a lot of options. Love to hear your thoughts. All right. So that's going to kind of help give us an idea of where people are at out there in the community as well. We have a lot of options now. Sometimes it's confusing for a lot of our colleagues to know what to pick now because there are so many options out there as well. And we're going to kind of use that poll later on and see where everyone is at after we have these great discussions and presentations. What are your thoughts, Luke, on that?
I think we should wait for the poll because the audience should also provide answers. And now we can introduce our speakers today. The first will be Priya Narang from India. I think second will be Dr. All, and then Dr. Hara from Japan, and Dr. Henning. So I think we will have a really interesting presentation, so we can go ahead.
All right. Fantastic. We'll go ahead with our first presentation then from Priya.
Hello, everybody. I hope I'm audible to everybody.
Yes, you are.
Yeah. So at the outset, I would like to start my presentation by first thanking Sergio and Ashwin for this wonderful opportunity. So I'm here, I'll be covering up the Advanced Vision Analyzer, and I will be giving just a brief overview of what actually this device is all about, since this is a glaucoma session. So I would like to introduce you Ava. Ava is a virtual reality headset perimeter, and what you see are the components of this device. It basically comprises of the head-mounted device, the patient response pattern, And what you see is the tablet, which is a test control device. And we have a fourth unseen thing here, which is a backend server, and we call it as a cloud, which stores all the data. So I'll just run you through this video. This just gives you an overview. This is the headset, which is worn by the patient. And it has an adjustable headband, which can be adjusted. It is connected to the patient response button. So whenever the patient sees the stimulus, the patient clicks it and the response is recorded. There is a test control device. This test control device, you feed up all the data of the patient, like what kind of, which eye, which strategy you want to do the programming, etc. So all the details are fed into this test control device, which is paired to the headset also via Bluetooth. So you have an eye tracking system, which helps you to track the eye movements, etc. So in short, this test control device is with the person who conducts this test, and it helps that person to regulate and see what actually the test is, how the test is progressing. So this device, Ava, it has the 30-2, 24-2, and a 10-2 program, and it has these algorithms, the ELISA fast. This is synonymous with the CETA fast of Humphrey. There's the standard algorithm and the full threshold algorithm. What also I would like to say that this device is US FDA approved. The key features of AVA are it is the white on white perimetry, and it also has the headset has the holder for correcting the refractive error. There's a lens holder which helps you to hold it up. The interpupillary distance can be adjusted. It has an eye tracking subsystem. The stimuli which is presented, they are the Goldman size 3. And there are catch trials also which are incorporated into the device, you know, they which is very essential. You know, you need to check for the false negative positives and also for the fixation losses. As I said previously, the device AVA has a cloud-based storage system which allows the users to back up all the test and report information, and you can also retrieve any data of the patient that has been done previously, and you can even transfer that data to another surgeon whenever needed for any opinion. The data of all the test reports can be easily accessed from the test control device also. So this device, it has its own normative database. The threshold measurements have been done for 174 eyes database it already has, and it is being recently upgraded much more for the statistical significance. The parameters, the probability limits have also been set up for the mean defect, for the total, and for the pattern defects. The assessment of the blind spot location testing has very accurate with this device. We have incorporated the blind spot and detection of fixation loss by the catch trial methods, and it has been found to be quite accurate. The test-retest variability of the device is bang on. The test-retest variability has been actually done thrice on same patients, and it has been assessed, and it has also been assessed according to the zones from central, middle, and from the peripheral zone. And it has the brilliant performance, and actually I cannot reveal too much of data here because actually this is in peer review as of now. But what I can say is that it's a very reliable results which have come up with AVA. This is how the visual field looks like. On the left, what you see is of the AVA, and on the right, what you see is for the Humphrey. So for all those people who they still think how to switch over, you know, this just gives you a brief overview of how the fields are going to look and how it actually represents the device. So there are various ongoing developments still with the device, which is working upon the progression analysis and for the EMR integration also. So there are various certain advantages. I would like to just sum up this with various advantages. The first thing is that it is portable. You can take this device anywhere. It's a lightweight device. The headset, you can even put it on patients who have neck deformities and other spinal abnormalities where, you know, they cannot position themselves on the traditional goal perimeters. So it's very advantageous for those patients also. There's no learning curve. It's actually a very simple device how to use it. We have done tests on this, and the threshold and the standard algorithms. There's a very accurate detection of the visual field effects. It is also very cost effective, and it is also especially very helpful in the rural areas. You can carry this device anywhere in the rural area. You can perform the test. You can share the report with an ophthalmologist anywhere across the globe, and you can treat your patients, and you can have multiple opinions of one single perimetry report. As I said before, it allows a lot of postural freedom to the patient, and it is especially very much useful, especially I would like to say currently as we are all facing the COVID-19 situation. It's very helpful in this current situation because the patient can perform the test by wearing the face mask. You don't have to, you can prevent yourself from getting directly exposed to the aerosols which are generated, and this is how this device, it can actually be helpful, especially in this condition where you really want to maintain your physical distance from your patient. So all in all, I would just like to sum up my talk by saying that this device, it's really promising, and I do promise to come back with much more data on this device. Thank you so much.
No, great presentation. Thank you so much for that. I've actually had experience with another company using the same type of virtual reality kind of goggles. I know there's a few companies out there making it. And I've noticed also from an efficiency and flow perspective, when you have 2 or 3 fields in your office, but you have a number of patients who require visual field testing, it can be difficult from a flow perspective. And so to have a few of these in the exam room lanes while they're waiting for me to come in, they can do the visual field right there and then I can use that for another patient later on in the exam room lanes. Have you noticed that too from a flow perspective?
Yes, we have. Yes, you're asking me?
Yeah.
Okay. Yeah. Yes, definitely. And what I see actually is that one of the other advantages, apart from what you are saying, what I feel is the patient, you do not require any specific space for that. The patient can be seated somewhere else, and anybody can do the test, and it's very helpful even in small practices. It can be very helpful. It can be an additional device which adds up to your diagnostic ability. Yeah.
Yeah. Love the panel. Go ahead, Lucan.
I have one question. Priya, do you see this device in the future, of course, as a home screening device?
I do. But yeah, we can do a home screening. There's nothing wrong about it because it's a portable device. Or maybe if I would like to go one step ahead, it can be something of a kind of a rental thing. If somebody does not really want to invest into this device, it can be done that way also. Yeah.
Yeah, I agree. I think with home tonometry now, as well as the visual field, we may have an opportunity to allow patients to go home for a day or two, do tonometry fields, bring it back, and we have better assessment for those patients in the natural environment.
Really, I do agree. It's a very nice device. The point is that we need more documentation about the comparison between it and the Humphrey. If you have papers published about it or any data, it will be very helpful to convince people to shift from the Humphrey to this portable devices with all the advantage of it. So congratulations for the nice presentation.
Thank you so much.
Yeah, I think the key is going to be as well is looking at progression analysis, more of the software, because right now that's pretty the most important part. Let's say the Humphrey Zeiss machines having Form and other software programs that allow you to integrate fields, optic nerve, fundus photographs, and to have more of that data out there is going to help a great deal transition.
Thank you.
All right, and I want to encourage everybody in the audience too. Don't hesitate. Please ask questions online as well. We'll try to be monitoring those questions on our phones here, so we'll try to ask those questions online as well. Thank you, Priya. That was a great presentation. Appreciate that.
Thank you.
All right, Lucan, who do we have next, my friend?
I think it's our colleague, Dr. O from Cambridge, or yeah.
All right, here we go.
Hi, everyone. My name is Leon, one of the consultants from Manchester Royal Eye Hospital in the UK. I'm going to spend the next 5 minutes briefly going over angle-based MIGS procedure. These are my financial disclosure. In 2021, we have a lot of ab-internal MIGS procedure. We also have some subconjunctival devices, but we won't be covering those in this brief talk. When we talk about MIGS and phaco combined, then we're really talking about angle-based procedure, and they're all offering very similar things. They lower the pressure to around about the mid-teens level, offer substantial reduction in medication, which helps the patient, and we're beginning to see some data that shows that it helps to delay the need for future glaucoma procedure. iStent is certainly the grandfather of MIGS. It started off with a single snorkel, then move on to the iStent Inject, which is one of the easiest device to use and certainly one of the most popular around the world. This year, we see the launch of the iStent Inject W, which has got a wider flange, which solves the problem of over-implantation, allow you to deliver 2 stents at the right place. And I think you're going to see some better results with the Inject W. It's certainly also the one that's been around the longest, iStent. We published the first 7 years series from the UK in Manchester, and it shows the pressure lowering to around about 16 level with reduction in medication by about 1 medication. The result seems to hold true for 7 years. Field, cup disc ratio all remains very stable. And even more interestingly and importantly, it seems to help to reduce the number of follow-up visits needed for the patient after the procedure. Hydrus has been a competitor for a few years, commercially available over the last 2 years. It's a bigger device. It takes the concept a bit further. It cannulates the canal for 3 clock hours. I think it's slightly harder to insert the device compared to the iStent, but when it's in, you know it's in. I think that the concept suggests that it's more likely to work because it cannulates the canal by 3 clock hours. In fact, there's some RCT showing that Hydrus is a slightly more beneficial or efficacious than the iStent. It's also the one that run an RCT all the way up to 5 years, and at 4 years is showing that inserting a Hydrus significantly lower your risk of needing future glaucoma procedure as compared to cataract alone. Hydrus is also the only one that's been looked at by Cochrane and received a favorable outcome. Cochrane seems to think that the evidence is of moderate certainty, showing Hydrus offers benefit over cataract surgery alone. If you're a fan of removing trabecular meshwork, trabectome has been through some changes, acquired by MST, and now there's offering the form of a goniotomy. There's also the Kahoot Dual Blade, which is very popular in the States. It remains very cost-effective in a way of removing trabecular meshwork. Our following speakers will tell you a little bit about how to do an ab internal removal of trabecular meshwork 360 degrees using a gap procedure, or you can dilate the canal using an ab internal canaloplasty using the LX device. They still lack the RCT that other MIGS devices have offered, although you can see plenty of prospective and retrospective single center results. This year, we also see the launch of Omni from Sight Science, which takes the concept of ab internal canaloplasty and trabeculotomy into one single useful device. And I like the usefulness of the handpiece, the design. You can see in the video, I ab internally cannulate the Schlemm's canal. When you roll the injector, the blue cannula goes into the Schlemm's canal 180 degrees, and when you retract it, it automatically delivers the viscoelastic you need to dilate the canal. You can turn it around, do the other 180 degrees, and then you can also recannulate the canal and pull to rip the meshwork at the same time, so give you some flexibility. RCT is yet to come, and we hopefully will be able to see some longer term results in the next few years. How you choose MIGS ultimately is down to surgeon's preference, your access, your reimbursement environment. But there's one thing that I would like to say about MIGS, and you can see graph like this all the time with mild disease on one end and advanced disease on the other. And often surgeons would like to sit MIGS somewhere in the middle after SLT and before traps. And I often feel that this one-dimensional assessment is somewhat incorrect. And I think at least we should think a bit more two-dimensional. Not only should you take the disease status from mild to advanced into consideration, but you should also think about the complexity, which is my vertical axis. Some cases are very mild but can be very complicated, like uveitis, and some cases can be very advanced but very straightforward, like an open-angle glaucoma. Medication SLT always sits at that end, and TRAP sits on the more advanced end, who can cater for more complicated case. And for me, the important thing is that I think canal-based surgery sits here in the mild to moderate disease. Reasonably straightforward and simple. It can certainly replace a lot of medication and SLT. The other procedures sit in a different place, and I don't think there is too much of an overlap. It's important to place canal-based surgery at the mild and moderate disease, reasonably simple cases. If you try it on the complicated cases, I'm thinking you're going to get some disappointment. Hopefully this is a quick overview of angle-based surgery. Thank you very much indeed for listening.
Thank you, Leon. I appreciate that. That was a fantastic overview. I know it's a lot to talk about in such a short amount of time. So well done. Unfortunately, Leon couldn't be here with us today for the live session here, but we have a great panel discussion right now, and I'd love to hear from everybody, Lucan and others. You know, what do you think is the hesitation for a number of our colleagues to offer, let's say, MIGS at the time of cataract surgery? I know there's still a number of people who are not offering. What do you think are the reasons why? Curious.
Let's ask our panelists, Dr. El Masri.
Yes, we know that the cost problem again of the MIGS is another problem that we face here in developing countries, because it's a relatively an expensive procedure in spite of being a simple procedure. So it's one of the main obstacles for using the MIGS and this eye stent procedure. The last thing that we used since a long time was the express shunt, which is of course now is out of date totally in the era of the MIGS. The point is that the presentation of Dr. Yu is very nice, and there are a lot of questions again for all of you, because still the experience and the false passage of the hydrus and the learning curve, I don't know whether you as moderators, you used it before or you have an experience about it or not.
Yeah, go ahead. Someone else had a thought? Great points. I agree. We have to balance efficacy, safety, as well as cost analysis. I have had a chance to use the hydrus. I was involved with the Horizon trials, as Leon mentioned. And actually, I don't think it's as hard as you think it is. I think what's nice about the hydrus is once you actually engage the TM and you're actually there, you just roll the wheel and it goes into the Schlemm's canal. Now, yes, you can get false passages. You can go into the superciliary space, but for the majority of patients, there's not a lot of hand manipulation. And I think my pearl to everybody out there in the audience, if you're thinking about MIGS right now, it's really all about the view. And I mean, for me, if you have a good view, if you can obtain a good view with your gonio prism, you master that skill set, then majority of the other MIGS, whether it's cutting, whether it's stripping, whether it's stenting, are very similar in terms of skill sets and something that you could adopt. And I'd love to hear everyone's thoughts. I mean, how do you pick between, let's say if you have a cataract, between a stenting, a cutting, a dilating procedure? Anyone want to ask for that question?
I want to comment again on the MIGS and cataract also. Apart from socioeconomic concerns, I think that the intraoperative gonio visualization is something that we are not really well trained. I was in the past part of the COMPASS study with the CyPass, and I was introduced to that. And there was nothing more complicated to do a cataract surgery along with CyPass. So probably the first stop is mental. We need to learn how to look to the angle. And a question which I would ask is, what's your favorite gonio lens which you use, and what is more convenient? For example, Mori, Hugh, Jacob, or something else, Ahmed DVX?
I prefer the copy lens during the surgery because it visualizes the angle very well. Another point is that what's the effect of this MIGS on the endothelial cell count? Is there an effect on the back of the cornea? If you have experience about it.
Yeah, we know that CyPass is already withdrawn from the market.
Yes.
Yeah,
I
but
think Horizon trial showed us with the hydrus, we have 5-year data shows stable in terms of ECL loss. So I think we're seeing now with the currently available MIGS procedures, as well as of course cutting procedures, we're not seeing the endothelial cell issues that we saw with the CyPass. So that is a good sign. I think what Leon mentioned earlier about the fact that 6% of people over 5 years needed incisional surgery, progressed to incisional surgery in the cataract only group versus 2% in the hydrus group does as a surrogate in some ways for progression. And believe it or not, 50% of the people who progressed to needing incisional surgery in that group actually were mild to begin with in the beginning of the study. So it just shows us that a number of our patients who are mild in the beginning, within 4 or 5 years, actually do need something more like an incisional surgery. So I think that's a value of hopefully decreasing compliance issues because of these MIGS procedures as well. Luke, any other thoughts?
I was just thinking to compare, for example, GAT, trabectome, and stents. What's your stand about that? What is your feeling? Which one is more effective, or do you have some tips for that?
Yeah, I have an algorithm which I can't share right now for the sake of time, but I do think that if I have someone who's a standalone, let's say a phakic patient who doesn't need, let's say, cataract surgery yet, in the United States, stents are approved only at the time of cataract surgery. So if I have a phakic patient, I'll do a number of viscodilating procedures, canaloplasty, whether it's the Omni without the otomy or just the eye tract catheter. And then if someone has more moderate disease or multiple medications, I will include a little bit of cutting as well as the viscodilation. If it's with a cataract surgery, mild disease, 1 or 2 meds, I'll do a stent alone. But now I've been a big fan of combining mechanisms. And to Ahmed's point earlier about cost, we have to balance that. But viscodilating along with stenting for me in the United States has really been a good benefit because we've seen a number of patients who are on 3, 4 medications. You're still in that middle teens with conventional pathway, but you're getting them patients off of medications more often than not by combining them different mechanisms as well. So I'd love to hear what is everyone else doing out there? What are you doing, Luca?
In general, I do either gut from a socioeconomic point of view, or I do express with deep sclerectomy. Here in Bulgaria is on off, either eye drops or either stenting. Stenting, I mean like trabeculectomy with a shunt or something like that.
Absolutely. And that is the balance. It's what's available in your area, what's your comfort level, and what's the cost analysis. And so there's no right or wrong, of course. And my advice would be, listen, if you're thinking about getting involved with MIGS, you don't have to do everything. Pick one in a category, one stent to try out, one viscodilating procedure, maybe one cutting, and then get yourself used to that, get the experience that you need. And then you can diverge and kind of expand your experience as well. Well, I know we would love to spend more time talking about this. It's exciting. I would love to do the whole talk on this, but unfortunately for time, we have to move forward. But thank you, everybody. We're gonna move on to the next speaker, and then we'll have some more discussion. So Lucan, what do we have next?
Dr. Takeshi Hara from Japan.
360-degree suture trabeculotomy of internal and cataract surgery by Japanese devices. My name is Takeshi Hara. Just a moment. 2020 and 2021 is the year of the Olympic Games held in Tokyo. I really wanted to welcome you to Japan. In this video, I would like to introduce you to MIGS using instruments developed in Japan. Tanito microhook was developed by Professor Tanito. This is reusable. This is microhook trabeculotomy of internal. I push the hook into the shram canal and cut trabecular meshwork. You can see pigmented trabecular meshwork is incised by microhook. This is Mori-Gonio lens. I can see the angle without tilting microscope. The lens has double mirror view and central view. In central view, we can see the disc at fundus of the patients, exactly glaucomatous capping. In double mirror view, we can see the angle without tilting microscope. This is 5-0 nylon by Professor Chin. By using these devices, I do 360 degrees trabeculotomy, short incision to meshwork by Tanito microhook. Chin 5-0 nylon. Place the Mori-Gonio lens on cornea. Insert 5-0 nylon into shram canal. Push the thread forward. Going on, continue. When you worry about where the suture is, by rotating Mori-Gonio lens, you can find. Finally, top of 5-0 nylon, come back through 360 degrees canal travel. Then I do cataract surgery. After lens implantation, I grab the tip of 5-0 nylon. Pulling from both sides, I do 360 degrees meshwork incision. Let's see the angle from inside. Sometimes trabecular meshwork is peeled off with the thread. This is angle before surgery, and this is after surgery. These are the angle before surgery, and these are the angle after surgery. You can see trabeculotomy. After washout OVD, blood reflex occurs from all around the corrector channel behind the Schramm canal. This is the angle observation 3 years after surgery. You can see dissected trabecular meshwork. And sometimes we can see blood reflex from corrector channel. Thank you for your attention.
Fantastic presentation. Thank you so much. That was wonderful, Takeshi. Appreciate that. I love the gonio prism you use, by the way. Do you use that gonio prism for all of your cases now, all of your MIGS?
Yes. I like double mirror type gonio lens. So sometimes I use Mori gonio lens, and sometimes I use Ahmed DBX. So I don't like tilting microscope in the surgery. So cataract surgery and MIGS, I go to smoothie. So I don't like tilting microscope. So because I use double mirror type gonio lens.
Do you find you need more light to get in to see the angle with that lens because it's a dual mirror lens? Or do you find that your light source is the same? Do you have to increase the light source during the procedure?
Right.
Do you find that because it's a dual mirror, you don't have to turn the head? Do you find you have to increase the light intensity?
No, same light.
Okay.
Yes.
Regarding the lens, it's a very nice solution, but I have a couple of questions about if you don't have a inclining operating theater, is it available to see all the angle without not directly? This is the first point. And the second point is there any difficulties during the visualization for the high myopes, the short axial length eyes, because it's a very interesting lens. So we want to know the details or the answers of these two questions.
Yes, usually I do the trabecular bypass MIGS after lens implantation. And I use very high viscosity hyaluron glue in Japan. And sometimes, so you say high myopic patient, this is anterior chamber volume is higher patient, it is difficult to see the angle because corneal fold, so we can see sometimes the angle. So I use more hyaluronic acid OVD to do MIGS.
Again, what about the hyphema, the instance of hyphema and the bleeding, which I think it's something to be considered. What's your opinion?
Yes, it is very important. Do not damage other inside Schramm canal. So I just insert my device, Tanito micro hook into the canal, and need to pulling to the anterior chamber side, this hook. So do not damage any other trabecular meshwork. It is very important to prevent bleeding, I think.
Quick question, a topic that comes up a lot is, do you stop blood thinners before you perform gap procedures or cutting procedures? Do you stop any blood thinners for these procedures?
Anticoagulants. Do you stop
Anticoagulants? Do you stop any anticoagulants before these procedures?
Oh, if patient use anticoagulation drugs, I do patient not stop the drugs. I do.
And is there any regimen for the post-operative anti-glaucoma drops in these cases?
Yes. Just after surgery, I stop all glaucoma drops. And when I check my pressure, sometimes re-add, sometimes restart glaucoma medication. And primary, I stop all glaucoma drugs.
Takeshi, quick question. Do you use pupil constrictors immediately after the surgery to avoid angiosynechia after cutting?
Yes, I use pilocarpine 2%. Just after surgery, 2 or 3 weeks.
Any steroids?
Yes, steroid 0.1% Brindelon.
Okay.
4 times a day and 1 or 2 weeks.
Again, what about
after 2 weeks? I see the angle. So if do not pass, I stop steroid and the pilocarpine.
what about the learning curve and the false passage again?
Yes, the 6 months I experienced a learning curve. Just beginning during the surgery, bleeding occurs, so I can see well. But after 3 or 4 months and after 6 months, I can see well without bleeding. So there is a learning curve for me.
Thank you so much.
Fantastic, fantastic stuff. Thank you so much for that. Yeah, I think my last pearl I would say to the audience, if you're thinking about doing cutting procedures, heme is an issue, of course. It's reflux more than bleeding. It's really reflux a lot of times from the venous system. The key is at the end of the case is hyperinflate the eye, overfill the eye, and then slowly decompress it. I find what happens if we hyperinflate the eye, stop the heme reflux. What happens if you decompress it suddenly, then within a half an hour or so, you get heme and post-op hyphema. So hyperinflate the eye, then slowly decompress it and keep it a little bit overfilled at the end of the case to allow yourself to prevent that hyphema post-op. But Takeshi, thank you so much. That was fantastic. I wish we could talk more again, but we have one more speaker. Arthur's going to give us some insights as well. Is that right, Lucan?
Yeah, Arthur Huning is next.
Thank you.
Okay, can you guys hear me?
Yes.
Okay, good morning. My name is Arthur Henning. I am from Santa Maria, Brazil. First of all, I would like to congratulate Dr. Argawal and Canabrava for the organization of the event and say thank you for Dr. Misha for the invitation. It makes me very humble and proud to be here on this position today, side by side to such fine gentlemen and ladies, of course, today. So first of all, do's and don'ts on a daily basis for your iStent application. So first of all, what is an iStent? iStent is a microinvasive glaucoma surgery that, by the way, is the smallest.
We don't see your presentation, I don't think. Are you sharing your screen?
Oh, so sorry. Let's go again.
No worries.
Share the presentation, Arthur.
There you go. Perfect. Now we got you. Thank you.
A little bit. So, do's and don'ts. What is an iStent? iStent, it's a microinvasive glaucoma surgery that stands for the smallest stent that we have on medicine nowadays that works as a trabecular bypass that we input on the trabecular meshwork, let's say to reinstitute the conventional way of the aqueous humor flow. So I base this class on the frequently asked questions that I get early from since I begin this from colleagues from all around the world, saying that you do that or you don't do this in order to have a nice indication for the stent. So believe it or not, the first question, the champion by far that I get from colleagues is, do I need to know gonioscopy to do that? My answer is yes, you do. You absolutely do. You must have a profound knowledge from the anatomy, from the cameral angle in order to do so. If you need any help, I highly suggest this website, gonioscopy.org, in order to do so. And the second one is, what's the best time to start the application, the stent application? Here we have a little algorithm for glaucoma treatment. And we have, let's say here, the first phase where we can do an SLT or medication. We can say today that SLT or medication, we can vary on the first or second phase as a second place. And then we have filtration procedures such as trabeculectomy or filtration devices. On the first phase, yes, we do go for an iStent. On the second phase, we say, no, we don't go. And why is that? Because on the first phase, we still have a functioning trabecular meshwork. The iStent is still going to work. And the second moment, no. And why is that? People ask me, so how do I know if the trabecular meshwork is still going to work? We don't have any direct exams to say that. No, we don't. But we do have these indirect signs to say if it's still in the work. And how do we know that? First of all, is the patient responding very well to medication or a laser that we apply on him? So the answer is yes. So we know the conventional way the trabecular meshwork is working. We know that trabeculopathy is more advanced on the more advanced case of glaucoma. So we know the more advanced the glaucoma, less inclined we are to apply the stents. So we have a patient that has already gone through a filtration procedure, like a trabeculectomy, for example. We say, no, we don't go for an iStent on this case. And why is that? Because the fistule that we create in the surgery or the device that we input in the patient's eye, the flow of the aqueous humor is going to prefer the fistula that we create and not going through the conventional way. So the stent will not work. A third question that I always get a lot. So can I put an iStent as a first procedure to lower my patient's IOP? I say, no, we don't. The SLT and the iStent, they have more or less the same efficiency. The reduction of the IOP goes around something 35 to 40%, or maybe 1-2 medications. So we always indicate for the patient first the SLT. So I really like this image because it shows we have these questions that we make. So we're going to put the patient, is the patient a remission or moderate glaucoma? Does it have functional loss? It's a severe glaucoma, it's an advanced glaucoma. So we see the more advanced the glaucoma, the less likely and less controlled the glaucomas were less likely to put the stents, were more likely to go for filtration procedures. So practical steps for us. We can apply this on a daily basis so you can see if it's a good indication or not. When you do gonioscopy, can you see the scleral spur for the patient? Does it have functional loss? On the OCT, how's the ganglion nerve cells? How's the optic nerve? How's the cupping on this patient? Does when he used to use the medication or the SLT, does they have good results with that? Is this glaucoma under control with that? Does it had already gone through an infiltration procedure in history? With these do's and don'ts, you can have a nice way to go through that. A little representation here on this video of what you don't want to do during the application. You can see here in the first video that I'm going to put, it's what you don't want to do. You put the device near to the trabecular meshwork, and you can see right over here that is not going all the way. You want on the Schlemm canal and go to the formula, really bypass through that. And here you can see, there you go, it's not all the way. You don't want that. You don't want that. You want to go all the way to create a bypass. Here we have a successful one. You can see the shot right here, a little sound. It goes like a click, all the way, a little reflex. That's a successful one. Okay, thank you for your attention. I'm open for questions. Thank you very much.
Thank you so much. That was fantastic. Appreciate that. Yeah, the iStent is definitely a great way to start getting involved with MIGS. I think you made a good point there, making sure you have a good view, making sure you can maximize your view of the angle structures and feel comfortable with the TM and how to identify different structures of the TM. I got a quick question. There's still a lot of naysayers with the benefits of MIGS. Arthur, do you find that your definition of success with the iStent or any of these MIGS procedures has to do with also medication burden reduction? Is that part of your definition of success?
Yes, absolutely, absolutely. And trabeculopathy associated with with your open-angle glaucoma. How do you know, like I said on the class, how do I know if it's working or not? So the patient, let's just say you have a patient with an IOP of 12 or 13 with a very good use of medications. But so he say, okay, I'm done with the eye drops. I want to go for an iStent, and I'm going to have cataract surgery, and I want to have the iStent. So the patient go for the iStent, and he stays with a stable 15 IOP. That's good as well, because he's not going to have any more peaks, because he's not having a fluctuation very high. You just want to stay that low, and if you can have a good results with that, I believe we can manage that. That's very good in my opinion. Yes.
There's a question from the audience. How do you prevent sometimes peripheral anterior synechia after the surgery, post-trab?
Come again, doctor? I didn't quite understand.
I think the question was, how do we prevent a PAS formation post, I think specifically in this question was post-trabeculotomy, but in general, how do you prevent post-surgical PAS formation?
Oh, in my practice, I always use pilocarpine, and I use a lot of steroids, because if the trabecular bypass or the filtration procedure is working, generally I don't have procedure with the IOP going up, because I never got pressure. Well, if it's working very well, I'm not going to have any problems with that.
I agree. And I think also if you're doing stents like the hydrus, et cetera, it's also where the hydrus, if you're not quite engaged fully into the Schlemm's canal, if it's dipping down, you might get some PS formation there. So it's also the placement of the certain stents. Yeah. And be careful. I've seen some eye stents being placed in the cerebral body. So you made a good point. Make sure you're the TM as well. Yeah, a real quick question about, or comment on IOP reduction versus phaco. We published a paper based upon the phase 3 trials, and we found that when you washed out medications, washed out patients, based upon their level of IOP, the higher the IOP, the more reduction of pressure you got with the iStent, versus the cataract surgery group maximizes IOP reduction 5.5 millimeters of mercury. So phaco does give you some reduction, but it doesn't increase the outflow facility like the stents do as well. So that's kind of more evidence that these stents are doing more as well. You had a good algorithm there. So you were saying for pre-parametric or mild glaucoma on 1 or 2 meds, that's when you perform the iStent. Is that what you were saying in your algorithm?
Yeah. Yes, absolutely. Because just on the prior class that we said before, that the socioeconomic factor in Brazil is something very important, okay? Let's say the minimum wage in Brazil is something around $200, and then an iStent application can go something around $2,000 in Brazil comes to the patient. So it's an important factor. So our experience on the social medicine show us that if the patient is not using correctly the eye drops, or it's not it's not very well controlled, yes, we always don't option for putting an iStent, because we don't know it's going to have a nice a good response. Well, we always go for the filtration procedure. We have a vast experience with filtration procedures here. So yeah, that's it.
If I might add, I think the most important thing is to intervene before the damage. So we will increase the time where the level or the quality of life and vision will be more. We don't need to wait eye drops to lead the patient to bad perimetry and then to intervene. I think that the MIGS place is immediately after the drops and way before the perimetric changes are bad.
That's a great point, Lucan. And think about it this way: the earlier we intervene, the higher the target pressures tend to be, right? And so therefore, when we talk about success of conventional outflow pathway MIGS, where the end result is usually middle to upper teens, a lot of these patients off of meds, that's okay for those patients. If we're waiting till they're more moderate to more close to advanced, then we're not as happy with the outcomes because our target pressures are low teens or even lower as well. So great point, Lucan. I appreciate that. I know we're almost out of time. Any last comments, Lucan? Go ahead.
We need to sorry to interrupt, but we need to share the results of the poll because they are quite interesting. And 30% are for trabeculectomy express in tube, and 46% are for MIGS. So nothing said about Zen and pressure flow. I think we forget about it. Why is that? Why? Do you have any comment, Paul?
Yeah, I think again, I think the cost for a lot of people around the country, around the world rather, the cost of a trabeculectomy is still much lower, and trabs do well. I mean, let's be honest with you, the trabs do great. I personally think there is a value to in post-op predictability, less number of office visits, less adverse events. No doubt, if you look at the Zen and pressure flow data, it does show that. And so that's where the balance comes with efficacy and cost analysis. I think it's going to take more time, but I think trabs are still a standard of care for a lot of people around the world.
Yes, I do agree with that, because even again in our developing countries, trab is cheap, effective. That's why most of the surgeons they can do it perfectly, and the success rate is high. So still, trabeculectomy, in spite of the advancement of the new surgical techniques, it has its standard role.
I think we're going to see these Zens and pressure flows much earlier than a trab. I think, like you were saying, Luca, maybe a more moderate patient on 3 or 4 medications where a conventional outflow pathway MIGS may not get them off the meds. Doing a Zen or a pressure flow may help. In my hands, that's where I use Zen a lot, is these earlier patients, more moderate, where they're not quite needing a pressure of 10, more middle to lower teens, get them off the medication. So I think that's where we're going to see these more stenting type of surgery.
Okay, I think our time is up. So it was a great session. Thank you all for the wonderful presentation and being here. And thank to Sergio and Ashwin for organizing this.
Very nice. Thank you again to everybody. Well done. Thank you so much. Be safe and healthy, everybody.
Thanks, guys.
Thank you.
Bye.
Bye. Bye.
FLACS session. The moderators: Robert Weinstock, USA, and William Tradler, USA. We welcome the panelists: Juvan Tidial, India. And featuring the speakers: Harvey Yui, Philippines. Christos Infantidis, USA. Nida Nikpour, USA. Nandini Venkateswara, USA. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
Hello, guys. I am here in the session because Bill is here. Hello, Bill. You can listen, Bill. You muted.
Oh, thank you so much. I was saying, let's kick things off because you're just such a great introducer, and well, it's such an exciting session on femto cataract surgery and all of the technologies for capsulotomy.
The sound is not good, but the session, you're the moderator, my friend.
Yeah, so let's kick it off with Dr. Yui.
Okay, let's go. Javi, are you ready, my friend?
Ready.
Welcome.
Oh, hold that. So you can see the slide?
Yes, everything okay, the slide okay, and your screen's okay.
Hello, I'm Dr. Harvey Uy from the Peregrine Eye and Laser Institute in the Philippines. And I'd like to thank the organizers for the opportunity to present on this topic. I received research funding from LENSAR. Femtosecond lasers were designed to facilitate the essential steps of cataract surgery, including anterior capsulorhexis, lens fragmentation, and clear corneal incisions. The LENSAR system has continuously evolved for perfecting refractive cataract surgery with the introduction of different new functions. High-resolution scanning, augmented reality modeling of the anterior segment, and tilt compensation help create a perfect capsulorhexis, which allows the intraocular lens to sit in a predictable, effective lens position, resulting in precise refractive outcomes. We all know that astigmatism is a major cause of visual impairment. Manual relaxing incisions are prone to inconsistent astigmatic correction. Toric IOLs provide a greater reduction of refractive astigmatism, but require accurate placement of the toric IOL. Femtosecond lasers can help reduce astigmatism by helping create more precise arcuate incisions and toric IOL alignment marks. Refractive surgery achieves better accuracy because the LENSAR employs iris recognition software to adjust for cyclotorsion. The LENSAR system imports topographic data from several topographers. The built-in calculation software then determines arcuate incision parameters and toric IOL alignment axis. In this arcuate incision video, the streamlined software matches the iris position when the patient lies down with the preoperative reference image and then adjusts the position of the arcuate incision to account for cyclotorsion. Our series of 25 eyes shows a significant reduction in refractive astigmatism following topographic guided arcuate incisions. For eyes with greater astigmatism, toric IOLs are preferable. The LENSAR system creates alignment marks on the corneal stroma or on the anterior capsule itself. This is called refractive capsulorhexis. The LENSAR system will similarly adjust for cyclotorsion and create alignment marks on the anterior capsule. Using this system, corneal parallax effects are eliminated, giving rise to more accurate placement. This video shows the very clear capsule-based toric IOL alignment marks at the start of the surgery, and these marks are still clearly visible after cataract removal. So all the surgeon has to do after putting in the toric IOL in the bag is align the markings on the toric IOL with the refractive capsulorhexis markings. And these have similarly given us very significantly accurate results after surgery. The group of Denise Visco reports better outcomes using refractive capsulorhexis compared to ink-based markings. Laser clear corneal incisions also achieve a better wound seal, which prevents inadvertent rotation of the IOL after surgery. Femtosecond lasers can reduce phaco energy and endothelial cell loss, leading to smaller amounts of corneal edema after surgery and hastening visual recovery. And we're excited to learn that the next generation of LENSAR, called the Ally system, features faster imaging, faster treatment times, incorporates a built-in Wortley phaco machine, and even manages to occupy a smaller footprint. The Ally system improves efficiency because you place the patient under the machine once, and after the femtosecond laser procedure, you just activate the Wortley phaco machine and do the phaco procedure without the patient moving. This helps with patient sterility and workflow efficiency. In summary, the LENSAR laser technology has continued to evolve to help surgeons achieve better refractive outcomes. Workflow efficiency is also improved with automated data transfer from topography systems. In our practice, we found the LENSAR laser to be a great tool for achieving the best refractive cataract surgery outcomes. And with the upcoming Ally system, we expect to see greater improvements in surgical efficiency. Thank you very much for your very kind attention.
Okay, take it away, Sergio.
Thanks, Harvey.
Thank you. Yes. Yeah, thank you, Harvey. That was an incredible talk, and the technology is so exciting. So we're going to save the questions and the conversation for the break. We're going to introduce our next speaker, which is going to be Christos. He's going to talk to us about Zepto.
Thanks so much, everybody. And hello to everybody tuning in from around the world. As Bill just mentioned, I'll be talking about Zepto, which is the precision pulse capsulotomy system and an alternative to FLACS for capsulotomies. I do have a relevant financial disclosure. Centricity Vision is the maker of Zepto, and I do consult for them. So what is the Zepto precision pulse capsulotomy system? Well, it's comprised of a handpiece that we can see here. And if we zoom in on the capsulotomy tip, you can see a silicone cup. And inside of this silicone cup, you could see a nitinol ring. This silicone cup is clear and allows the surgeon to align the capsulotomy on the patient's visual axis. This handpiece is connected to the control console, as we can see here. This control console delivers not just the energy, but also applies the suction to the anterior capsule. So you applanate this cup to the anterior capsule, suction is applied until you reach a critical mass, and then you can deliver the energy. Inside of the handpiece, there's also a rod, as we can see here, that is extended through and engages the nitinol ring. And when it's fully extended, will collapse the nitinol ring and the silicone cup, making a functional taco shape here that can fit in any wound through the cornea that's 2.2 millimeters or greater. Here you can see on the left a picture of the folded device being inserted into the eye, again, 2.2 millimeters or larger. Once it's in the eye, you can retract the rod and that'll expand the nitinol ring and the silicone cup. It returns to circular form, and then the surgeon's able to center the device on the visual axis, which is unique because typically, whether it's FLACS or our manual CCC, we typically will do it on the optical axis, but this allows us to really center it right on the Purkinje 1 image, right where the visual axis is of the patient, and that'll help with especially premium IOLs like multifocals and torics. Once it is in the right position, you retract the rod even further, and you will begin the aspiration and suction step. It applanates against the anterior capsule. Once a critical level of suction is achieved, the machine will tell you that you are ready to proceed with the energy step. And then 12 micropulses of energy are applied over 4 milliseconds, so very fast. And it creates on average about a 5 to 5.2 millimeter capsulotomy. Let's see it in action here. You can see me checking the rod to make sure that it's engaging the nitinol ring. That's a critical step in the process to make sure that when you extend the rod that it's actually going to collapse the nitinol ring and create that taco shape. And here you could see me collapsing the device. And then this is sped up a bit, but we're going to insert the device into the eye and retract the rod. The ring expands, centering it right on the patient's visual axis. Aspiration and suction against the anterior capsule, and then energy delivery. Again, this is sped up. Then we release suction, which has a little bit of a reflux back into the AC. And at the end of the case, you could see well-centered lens, a capsulotomy that is also centered on the visual axis. And we've got 360 degrees of overlap, which is critical, especially for premium IOLs and torics, to prevent tilt long-term. If we zoom in and look at a electron microscopy image of the capsulotomy, we could see a cartoon schematic here in the top left panel A. You could see the surgeon's workspace is right here, and the functional edge of the capsulotomy, when looked at under electron microscopy, is very smooth, and the overturned edge, the part that's rolled over, may not be, but the functional edge, the part that we care about, is smooth. And you could see that in panel C even closer up. And when we compare it to manual CCC, you could see a big difference here between the edge. So does that matter? And the answer is yes. Because of the electrical pulse that does that, we can see here out of a study from Vance Thompson's group, you can see on the top a manual CCC as force is applied on both sides of a capsulotomy. Of course, it'll break eventually. And right there, you could see the manual break, but the Zepto on the bottom, over 3 times as much force before it breaks. And so one of the unique things that we can get from Zepto is an even stronger rhexis, and that really plays an important part. especially for complex cases. These are just some of the cases that I do at Denver Health, where it's a level 1 trauma center. We see a lot of traumatic cataracts, a lot of phacodenesis. So if I'm putting in an OMED segment, I can be rest assured that there'll be the proper amount of structural support there for an OMED segment or capsular hooks during surgery, so that the anterior capsule does not break. If you want to learn more about both routine and complex cases for Zepto, we published in the last year a paper that looked at about 340 surgeries by 4 surgeons. We found that 99.4% had free-floating capsulotomies, which is a concern with any automated capsulotomy device, whether it's FLACS or Zepto. We also reviewed 52 surgical videos, and we found that the mean diameter was about 5 millimeters, which is a great size that most surgeons really enjoy having. And then 98% of the cases had 360 degrees of capsular overlap. And we know that's important, especially to prevent IOL tilt. And then finally, outside of routine cases, we highlight some really unique cases that we all, as the 4 of us, were able to do, including phacodenesis with OMED segments, penetrating eye injuries through the capsule itself, very dense fibrosis of the anterior capsule, and then even open sky cataracts. And as Bill mentioned, I'll take any questions at the end, and I really appreciate the opportunity to come and speak to you today. Thanks so much.
Chris, that was beautiful. And it's really nice to see that while the technology is so exciting, it's actually complementary to Femto as well. So we'll talk about that in our discussion, because I know we're running a little bit behind time. I just want to remind everybody that we do have a question. And the question is, if you could answer this, whether in your practice you currently perform Femto or not. So if you could answer that, we'll announce the results at the end. And with that, we're going to jump to our next speaker, Netta Nikpour, who's going to share with us another Femto technology called Zemer.
Hi, I'm Netta Nikpour. I'm thrilled to be a part of this year's World Webinar on Cataract and Refractive Surgery. It's really an honor to be able to share with you why the Zemer Z8 is my Femtosecond laser of choice. These are my financial disclosures. As a little bit of background, I did my residency and fellowship at the Bascom Palmer Eye Institute in Miami, where I was very fortunate to gain experience using all 3 of the major laser platforms, the LensX, Catalyst, and Victus. I'd never even heard of the Zemer before I started at my first job at Envision Eye Centers in Orange County. For those of you who've never seen the Zemer Z8 laser before, it's a pretty slick device with this articulating robot-like arm and a large touchscreen HD monitor. When I first saw it, I was a little intimidated, and I thought it was going to be really difficult to learn to use it, but it really wasn't that hard. I'd used the Zemer for a few dozen LASIK cases when I first started, but when my first day cataract surgery rolled around, I thought I should stick with one of the platforms that I'm comfortable with. So here I am, on my very first day of cataract surgery at my first job. My first patient on that day was a sweet woman who wanted a multifocal lens with Femto. So I get her under the laser that I was comfortable with, and no matter what I did, I could not get suction. I tried for over 10 minutes. I did everything I could think of. I even had 4 reps from the company that were supporting me that day. They tried everything they could, and then finally they said, "I'm sorry, there's a technical problem with the laser, and we're not going to be able to fix it today." Okay, so I turn around and I asked, "Is the Zemer rep still here?" Fortunately, the Zemer rep was next door training another surgeon, and he was able to step in and train me on the Z8 right then and there. I was amazed at how easy it was to use, and thankfully I was able to complete all my cases that day without skipping a beat. Besides the articulating arm, which is really no big deal at all, the other thing that I thought would be a challenge was the docking. But as you can see here, the docking is actually, in my opinion, even easier than it is with the other laser platforms. First of all, you place the suction ring under direct visualization, and you don't have to crouch down under a bulky laser head. Head tilt doesn't matter at all because you snap the handpiece into the suction ring and you can move in any direction you need to get it to line up. So even though they quickly fixed the other laser, I'll tell you why I changed over to the Zemer and never looked back. This is a long list of all the technical and procedural reasons why you should use the Zemer, and we can review these at some other time because the real reason that you should use the Zemer laser is because your staff are going to love you when they get an extra 5-minute coffee break with all the time you're saving. It's really that much more efficient to do the whole procedure sterilely. As you can see here, the workflow is really where this laser shines. This video shows a side-by-side comparison of the same surgeon using the Zemer and the LensX. What you'll see is that he finishes both procedures at about the same time, but when he finishes with the Zemer, he just starts his case because he's scrubbed in, sterile, ready to go. It's efficient. The technical specifications are on par with any of the other lasers. Let's face it, when we get down to comparing nitty-gritty laser specifications, we're really splitting hairs. At the end of the day, they all meet a minimum standard. The important thing to us as efficient cataract surgeons is how much time is this going to add to my case. The Z8 is way more efficient. That being said, there are some of the technical specifications that are worth a few words. Because it has the lowest pulse energy, a liquid interface, and an overlapping cutting pattern, the corneal incisions are the best I've seen with any laser. Low energy also means that you won't see the pupil come down, and the cortex isn't as sticky. And in my experience, these are often the main barriers for surgeons who are thinking about using femtosecond laser technology. Also, the capsulotomy is as strong as a manual capsulorhexis, unlike with other laser platforms, so it's safe. Finally, the Z8 is the smallest and only mobile femtosecond laser, so you can even share it with another surgery center and reduce your cost. In my opinion, these are the key advantages of the Z8. The technical specifications directly translate into better clinical features. So clinically speaking, because of the low vacuum and the liquid interface, I find that patients are more comfortable and there's less subconjunctival hemorrhage. I also find that the pupil doesn't come down as much. I used to use sugarcane with every other laser platform, and I found that with the Z8, I really didn't need to do that. As far as the workflow, these are the key reasons why the Z8 is my go-to laser. Being able to share the laser between different surgery centers is a truly unique feature. The laser takes up very little room in the OR and is easy to use for the surgeons and staff. It's very efficient. Finally, and most importantly, because the Z8 can be used sterilely, it is one concurrent procedure for the patient and the surgeon. That saves a lot of time and makes the Z8 my femtosecond laser of choice. Thank you.
That was wonderful. Netta, thank you so much for sharing that. Great technology, and we're going to just jump right into, again, trying to get all the presentations in first before our discussion. We're excited to have Nandini present on the catalyst, and we'll hear her thoughts on this technology. And then we'll have at the very end a nice discussion, and then also a reminder, please answer, if you haven't answered already, the question is whether or not you're currently performing femtocataract surgery. So Nandini?
Sure. Hi, everyone. Thank you so much for the honor to be able to share my experiences with the Catalyst Precision Laser System. I'm speaking to you all from Boston here at the Massachusetts Eye and Ear Infirmary. Can everyone see my screen? Okay, so of note, I am a consultant for Johnson & Johnson, and I thank them for some of the materials that I'm sharing with you all on the slides today. So I'd like to touch on 3 of the key concepts that make the Catalyst Precision Laser System unique for femtosecond laser cataract surgery. And those include the liquid optics interface, the graphical user interface, as well as the integral guidance system. And I think they all work seamlessly to help us as surgeons perform state-of-the-art femtosecond laser assisted cataract surgery. So let's start initially with the liquid optics interface system. So in this video, you can see a surgeon begin docking the Catalyst laser. She places the suction ring on the patient's eye, has the patient fixate, and obtains vacuum. You then fill the suction ring with sterile BSS solution and easily move the integrated bed underneath the disposable lens on the laser platform. That lens is immersed in the balanced salt solution, and the images are then locked and captured, and you begin seeing your OCT imaging for your plan. If we look at a closer view of the suction ring, the nice thing is that there's 2 different options, a small and a large size. And this can help the surgeon customize the fit based on difficult lid fissures or a smaller orbital anatomy. Similarly, you can actually align the hash marks in the suction ring to marks that you make preoperatively to account for cyclotorsion. Once you achieve vacuum, you can easily fill the suction ring with balanced salt solution. You want to ensure that there's no bubbles, and you can move the patient under the disposable lens and easily dock that disposable lens into the balanced salt solution. You capture the suction ring and the lens together and lock it into place, and you can begin to see the OCT images. I think that the liquid optics interface allows for a very soft and efficient dock for my patients. There's a minimal intraocular pressure rise, especially when we consider our glaucoma patients, and patients aren't telling me that they're having these sudden blackouts of vision or transient episodes of vision loss. Because it's not an applanation interface, there's less of a risk of developing corneal folds. So there's going to be a lower risk of creating incomplete incisions or capsulotomies that can be troublesome intraoperatively. Similarly, without applanation, there's less of a risk of pupillary meiosis at the time of surgery. And lastly, I find that my patients have lower rates of subconjunctival hemorrhages, and this proves for improved cosmesis postoperatively. Once I've docked the laser, I can then actually confirm my surface plans. And here you see the high resolution OCT images that are live streaming. They're automatically mapping the anatomic surfaces of the multiple landmarks in the anterior segment. And the user interface is very easy to use. I can zoom in, zoom out, rotate, and really customize the view to see what I need to confirm my patient's treatment plan. There's also a vector force diagram on the upper left that I'm watching the whole time to ensure that my patient isn't exerting excessive vertical or lateral forces that may threaten a suction loss. So oftentimes I'm placing my hand on the patient's forehead and ensuring my little black arrows within the safety margin to ensure I don't have a suction break. The capsulotomy in the Catalyst laser is really quick. It can be done under 1 to 2 seconds, and in the literature, over 99% of the cases have had a 360-degree capsulotomy. But what's unique to the Catalyst laser system is actually the concept of a scanned capsulotomy. So in most patients, laser platforms or surgeons may center the capsulotomy on the pupillary dilation. But if the patient has an inhomogeneous pupillary dilation, this can actually cause decentration of the capsulotomy, as well as the intraocular lens. But the Catalyst laser allows you to actually map out the true anatomic center of the capsular bag and actually place your capsulotomy to center it in that location. And this allows for improved visual outcomes in our patients who receive premium intraocular technologies. You can also customize your lens fragmentation pattern. So not only can you fragment the lens into, say, quadrants or sextants, but you can also soften the lens using customized grid patterns. You can change the sizing and the spacing of the grid patterns based on the density of the cataract. So on the right-hand image, I've really used a very tightly spaced and small grid size pattern in addition to fragmentation to help with a very dense brunescent cataract, reducing my time and energy in the operating room. I can then also customize my incisions, the location, as well as the side cut angles of the anterior and posterior aspects of the incision. You can create arcuate incisions that are anterior penetrating, which can be opened at the time of surgery, but also intrastromal incisions, which are going to be primarily used in my practice to allow me to understand the location of my toric IOL alignment intraoperatively. And then finally, I can look at my entire plan summary here in this user interface, and I can also tell my patient what the expected treatment time is. My treatment times are typically about 30 seconds or less for my patients. And so ultimately, I'm able to create a very seamless surgical experience for my patient, and it really induced minimal corneal edema and inflammation postoperatively. A new and exciting software update with the Johnson & Johnson Catalyst portfolio has just rolled out in spring of 2020. It's called the COS 6.0 software, and I think it offers many exciting advantages for surgeons. It has a built-in arcuate incision calculator, and it also allows for the placement of more precise radial laser marks for toric IOL alignment. And with certain topographic machinery, we can actually directly input preoperative data for automatic iris registration and automatic cyclorotation compensation, which can really simplify the workflow for surgeons. So in summary, I think the Catalyst Precision Laser System offers many advantages, and it's really simplified and eased my workflow in the operating room, and understanding its unique features has helped me really improve my patients' visual outcomes. Thank you so much.
Thank you, Nandini. That was, of course, wonderful. You're always such a great presenter. And now we're going to move to our panel session. We have about 10 minutes for our panel discussion, and I'd also like to introduce or invite Dr. Tidial, who's one of our panelists, to also be part of this. So let's jump to Dr. Yui, and we can talk with everybody. How do you guys manage the most difficult cataracts, the very dense cataracts? Oh, can we have everybody up on the, if it's possible, have everybody up on the Zoom screen? And then, Dr. Yui, why don't you jump in? How do you manage the most dense cataracts? Do you feel comfortable using femto? Does it make a big difference? Dr. Harvey Yui?
Yeah, seeing you, Bill. Yeah, in our neck of the woods here in the Philippines, we have the densest cataracts you can imagine. And what I really appreciate about the LENSAR system is that it has a system to automatically grade cataract density and select automatically the optimal treatment algorithm pattern. So it helps do the surgery more efficiently, and it makes life easier for the surgeons.
Oh, thank you so much. Now let's jump to Christos. Now, Zepto, you have Zepto, and let's say you have femto at your practice. Christos, how do you decide whether to use Zepto for a patient or femto for a patient that has a very dense cataract?
That's a great question. I mean, for me, I really see, just like in the Philippines, we get a lot of patients from all over the world at our practice. And so for me, having a very strong capsulotomy is important for dense cataracts, because when we're taking a piece out after, let's say, a chop technique, putting stress and strain on that anterior capsule is a big deal. And I'm sure a lot of people will run into that at some point in their career, where a piece itself can actually, as it's coming out, put enough tension on the anterior capsule to create an anterior rent. And so for me, I get added benefit and reassurance from the zeptocapsulotomy, as you saw in that video with the stretch, that for even the densest cataracts, I prefer zepto because of that added strength.
That's really helpful. And Nandini, we'll jump to you. Yes.
I like to invite our panelists, Jill, to discuss too.
Yeah, thank you.
Yes, no, it's definitely going to jump, because I wanted you to do a summary of after the three people gave, but we'll jump in with you. So tell me your experience with femto and what are your thoughts on probably let's focus on the denser cataracts. How does it help you in your practice?
Yeah, thank you, Will. I think all the talks were wonderful regarding Femtosecond. And as far as denser cataracts is concerned, I do feel Femtosecond does give us a lot of advantage in getting a good decrease in the nuclear emulsification power-wise. And I personally use LenSx more often than other systems. And in the recent past also, we have compared grade 4 nuclei with various patterns of nucleotomy fragmentation. And we found that if you have a grid pattern, is far better than a chop pattern in these cases, to decrease the energy level by another almost 30% in these cases. And the chop in all these, I have used Catalyst, also used LenSAR. The chop is very effective, and you can separate the nucleus very easily after a combination of fragmentation and chop pattern. So I do find this is very, very good asset for a denser nuclei, which is very common in the Asian countries.
Beautiful. And do you have any experience with Zepto yet? Just curious.
I have done a few cases. I don't do regularly, and I don't use Zepto just for a harder nuclei, because capsulotomy or a capsulorhexis is okay. It's a concern, but it's not a big concern for a harder cataract. It is the softening of the nuclei which is more important in these cases, which is, I think, best with Catalyst and LenSAR platform, even GMR also.
Thank you so much. That's perfect. And now we'll jump to Nandini next. Nandini, we'll just share your experience with the denser cataracts and femto. Has it helped you in your practice? I know, Nandini, you've been in practice for about 2 years, so just share your thoughts.
Yeah, absolutely. I think I really encourage patients to utilize the femto if they can for the very dense lenses. I think the capsulotomy is often the most challenging part, especially in my white cataracts or my very shallow chambered brunescent cataracts. If I can get a good capsule, 50% of the tough part of the surgery is done. And then in the Catalyst specifically, I think the combination of the fragmentation and the softening has been very helpful. I've actually tried many different fragmentation patterns and softening grid patterns and customized what I found helps me be most efficient in the operating room. And I found that my cumulative dissipated energy is much lower and my patients have much less corneal edema post-operatively with those fragmentation patterns. And I think also for the docking purposes, the liquid interface really helps me for patients with challenging anatomies, especially if they have smaller orbital fissures and dense lenses. I actually had a patient yesterday that I tried to dock for almost 20 minutes. She's monocular on the LenSx platform and I couldn't get it. So I'm actually bringing her to my other surgical center with the Catalyst to do it. And she has a very shallow chamber and brunescent cataract. So all of them have their advantages, but I think we can mix and match them sometimes based on the patient, on the density of the cataract, etc.
Beautiful. Sergio, your thoughts?
My experience with Catalyst in my hospital, I have only Catalyst too, but I use it more for subluxated cataract. I don't like to use femto to hard dense cataract. I prefer to use my routine to subluxated cataract.
No, that works good. Now let's just jump to astigmatism management because that's some of the features of some of the femtos. Dr. Harvey Yui, just share your thoughts on how it's made a difference in your patients with astigmatism.
We find that the Lensar system we use is a godsend for treating astigmatism. You can use arcuate incisions to decrease corneal astigmatism, and we really love these corneal refractive capsulorhexis marks that make it very easy for us to align the toric IOL along the correct axis. And all of this is done automatically. You input data from topographers. The software calculates where you should put the arcuate incision and where the toric IOL should be aligned, and then it does everything for you. So all you have to do is put in the toric IOL and then rotate it to the correct position, and you get a bang-on good result.
Beautiful. So Dr. Chitiel, how about yourself? Have you had experience?
Just want to put a comment on a refractive capsulotomy with the Lensar system. And apart from helping you in intraoperative alignment, it is a great help in a post-op assessment also, because you have that refractive tongue, and you can analyze your lens being right in a position, or it's gone shifted from the side, and it's helpful in that direction also. And we have found it is very, as Yui said, it is a very helpful. Is comparable to your image-guided alignments.
Beautiful. And I know, Nandini, your system also, the Catalyst, just recently launched the astigmatism part. Can you just share, Nandini, your thoughts on the Catalyst for astigmatism management?
Sure. So I haven't used the upgraded software yet, but I think it's going to simplify the workflow so much because you can actually import preoperative data right into the machine. It has the built-in Donnenfeld nomogram in order for you to plan your astigmatic corrections and also make intrastromal markings for your toric IOL alignment. Right now, for me, it's quite simple. I do these measurements preoperatively. I make my plans and send it to my surgical center, a week before my case. So everything's pre-planned before I walk into the operating room. But I have found that for astigmatic correction, the precision and the location of the incisions has been great. I open many of my incisions, the anterior penetrating ones, in the operating room, and my intrastromal marks are very helpful for me post-operatively when I'm ensuring that my toric IOL is in the correct position. So I think the new software is going to be exciting.
That's awesome. That's exciting. Now let's jump into Christos with Zepto. Christos, how are you marking for astigmatism in your practice? If you're using Zepto, what's your pearls?
Well, in terms of, so if we're using Zepto, just the traditional toric markers, I think it's pretty straightforward manual marking. Hopefully in the future, we'll be able to use the Zeiss platform. We're hopefully upgrading to that so that it'll have mapping of the iris intraoperatively. But for right now, we just use the traditional hand marks for the toric placement.
Beautiful. No, thank you so much. Well, I think we're going to try to keep on time as best as possible. I want to just thank our speakers, our panelists, and of course, my co-moderator, Dr. Canabrava. And we would thank you all for being part of this. Dr. Canabrava, can you just share the final poll results? Do you have that handy that you could share the final poll results to the audience?
Yes, the results, yes. No for 60% and yes for 40%. The polls was, are you currently performing phantom cataract surgery at less ounce per month? Then no, won 60%.
Beautiful. Thank you so much. Do you want to sign off for us?
Guys, thank you. It was a pleasure.
Thank you, everyone.
Thank you, everyone. Good session. Thank you.
Virtual live surgery session. The moderators, Namrata Sharma, India, and Sergio Canabrava, Brazil. We welcome the panelists. Ivo Ferreira, Mexico. And featuring the speakers, Geraldo Barbecchia, Argentina. Bruno Fontes, Brazil. Michael Greenwood, USA. Ignacio Manzitti, Argentina. And Luis Fernandez Vega, Spain. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
Hello guys, it was a pleasure to be here in this amazing session with my core moderator, Dr. Sharma. How are you?
I'm good, great. Fantastic webinar which is going on.
Yes, now we present the live surgery. It was a virtual pre-record live surgery. It was a great challenge. And after the end of the live surgery, me and Dr. Narendra Sharma will ask the surgeons. Ignacio is here, Michael is here, and Geraldo is here too. And Bimopki, if you can't, Bruno here too now. Bruno, how is it going Rio de Janeiro, my friend? Let's let's start the virtual live surgery now.
Welcome to the virtual live surgery. Today I have 5 amazing surgeries and surgeons. Dr. Valvecchia from Argentina, Dr. Ignacio Manzitti from Argentina too, Dr. Bruno Fontes from Brazil, Dr. Luis Fernandez Vega from Oviedo, Spain, and Dr. Mike Greenwood from United States. I will start with my friend, Dr. Valvecchia. This guy teach me how to do this kind of live surgery, and in September have a Faco Extrema. My friend Valvecchia, how is it going? Are you ready?
Hello, my friend. Hello, Sergio.
Hello, Sergio. How are you?
We are with Gaston waiting your order. We are drinking a coffee now.
Valvecchia, you are not ready, my friend. Go to operating room. I will start the another surgeries, and I back to you when you're ready. Bruno, Rio de Janeiro.
Hello guys, I'm about to start my day. Today I have around 15 cases. My IOLs are here. I'm gonna show you a case of high hyperopic in a very old patient. He has a very shallow anterior chamber, and I implant a Technique eye hands plus 30 in this patient. See you soon.
Thanks, Bruno. Now you go to Oviedo with my friend Luis Fernandez Vega. Luis, I think you are in the operating room now. You start to insert the Canabrava ring, right? Let's go, my friend.
Thank you, Sergio. Yes, we are now inserting the Canabrava ring. As you see, the pupil is small or medium size. We prefer to have a little bit bigger size, so this is why I decided to use the ring. The patient has a shallow anterior chamber of 2.1 millimeters, so this is a great advantage of the Canabrava ring that can be used in shallow anterior chambers without a problem. The technique of placing the ring, it's easy. Of course, it has a learning curve as any of the maneuvers that we can make during the surgery, but once you use it a couple of times, you won't have problems at all.
Luis, thank you. I back to you in minutes. Ignacio is starting in Argentina. His case, Ignacio, are you ready here, my friend?
Good morning, everyone. Hello. Here we are with Fernanda. I'm Ignacio Manzitti from Argentina. We're going to do this case of a man who has a subluxated IOL. We're going to try to do either a suture technique or a glued IOL technique. So we're gonna start the surgery and we will decide on its way. Let's start. Thanks.
Thanks, Ignacio. Luis, are you finished to insert the Canabrava ring?
Nearly done here with this first step of the surgery, Sergio, and we will have now a very nice pupil of around 6.3 millimeters.
Thanks, Luis. Ignacio, how is it going? Tell us about the case.
The corneal diameter is 11 millimeters. Let's start with iris retractors, please.
Thanks, Ignacio. Let's go to see about Luis. He is removing the visco to go to the femto. Luis.
We are almost done to go to the femto. I'm removing the visco through the main incision. The Canabrava ring can be inserted through a small incision of 1.4. So it's a great option to insert the ring and then go to the femto. Otherwise, wouldn't be possible if we wouldn't have placed the ring to make a femtorexis with this patient. Let's go.
Great job, Luis. I think you are better than the inventor to insert the ring. Thank you. I go now to see how he's doing with Ignacio. Ignacio, what's happening, my friend?
It looks like it is a PMMA one-piece IOL, so I'm going to try to suture the upper haptic to the sclera because it is very difficult to do a glued IOL technique with this type of IOLs.
Ignacio, you go to Rio now. Bruno is starting his surgery.
Let's perform the capsulorhexis. Capsulorhexis. And up. 2 to 2.5 plus nuclear cataract. After the dissection, you can see the first wave. I like to manipulate and rotate the nucleus. You can see that it's a
Bruno, let's go to Argentina. Let's see how is the Ignacio surgery.
Hey Sergio, while you were in the other surgeries, we just noticed that the IOL is not a PMMA, it is a 3-piece. So we will change plan and we will do a glue IOL. Please give the forceps, please. It's moving. Hold. Where are you going? Stop there, please. Oh my God, 1 second late. I don't see it. We're gonna do some posterior vitrectomy and go and find the IOL in the back of the eye probably.
Ignacio, we believe, our world believe in you. prepare your vitrectomy. I'm sure you back with this IOL for the anterior chamber. While you start the vitrectomy, you go to see how is Bruno's surgery.
Modify. Wet the cornea, please. Just chopping and removing the nucleus. Modify. Is almost done.
Thanks, Bruno. I back to you when you start to insert the IOL. Inácio, start the vitrectomy in Argentina. Inácio, what's happening?
Good, now we have one haptic outside of the eye, and we are going to do the handshake technique so we can catch the tip of the haptic with the right hand and pull it out of the eye through the sclerotomy on the right side.
Inácio, great job. Now go to Spain, Oviedo again. Luis, we'll start the femto in this moment. Luis, tell us what is happening in Oviedo now.
So we are ready in the laser room. As I said, catalyst, and you can see there the Canabrava ring perfectly placed and holding the pupil. We are going to do a capsulorhexis of 4.8 millimeters. We always use this size in Panoptix IOL. Here you are seeing a very nice image of the Canabrava ring holding the pupil, and we are ready to start the femtolaser. The AC does not suffer at all. Aguante. And we have 20 seconds remaining. We are nearly done with this part, and we will be ready to send the patient back to the OR and continue the surgery. Thank you.
Luis, great. The femto was amazing. Let's see how is Inácio going.
These tunnels are done with a 27 gauge needle, and then we place a spatula with some ink on it so we can visualize it better. We can now do the same thing on the other side with the 27 gauge needle and the spatula, where we have to place the left haptic.
Inácio, great job. Bruno is ready to insert the IOL. Bruno, I believe you implant enhanced IOL, right? Show us, my friend.
And here's the folding mounting of the Technis enhanced IOL. It's pretty much equal to the Technis ZC Boo model. Let's prepare for mais implant here. Tá tudo ótimo, se você é bem quietinho. And now is the IOL implantation. It's a 30 monofocal Technis enhanced IOL. Just place it in the bag, and it's very smooth. Goes very smoothly. It's opening. Okay. Now, only the removal. You can see that it has a dry eyes.
Thanks, Bruno. I wait to you in the end of the session to discuss. Don't go to the beach now, please. And I wait to you to discuss about your case. Valvecchia is ready to start. He has an amazing case for us. Valvecchia, let's start.
And I made the first incision perpendicular to the limbus in the sclera. We are ready to make the pocket, the scleral pocket with the 25 gauge balance. We'll repeat the maneuvers at the opposite side.
Thanks, Valvecchia. Now we go to United States. Mike Greenwood have a great case of phacoemulsification plus a glaucous stent. Mike, let's start.
Hey everybody, I was getting excited watching all of these complex cases, so I decided to start my simple one a little bit earlier. So you can see here we're just getting going on the capsulorhexis, and this is a patient with visually significant cataract and mild glaucoma, well controlled on one medication. So we're going to go ahead and wrap up this capsulorhexis here and take out the cataract and then place 2 iStent injects from Glaukos, as you mentioned, and just burping out a little viscoelastic here. And I'll go ahead and do my hydrodissection. I like to do a decent amount of hydrodissection so that the lens rotates freely and doesn't put any stress on the zonules while we're removing this cataract here. So I'll keep plugging away here on the cataract, and we'll update you as we get going. Appreciate you guys tuning in and spending some time.
Let's go to Oviedo, Spain. Luis, you start the phacoemulsification after the femtosecond laser.
That's it. We are back in the operating room. I have to open a little bit more the main incision. Remember that it was 1.4. I usually do my cases in 2.2. And you can see a perfectly center capsulorhexis in the apex of the lens, which is a very big advantage of Cataly's femtolaser. Once I get the visco back into the AC, I'm going to remove the capsulorhexis. First, I like to check that there is no breach that can give me some tears in the rhexis, but here the rhexis was perfect. Déjame I'm going to do the hydrodissection. Perfect. Thank you. And I rotate the nucleus so we can start the phacoemulsification. Thank you. That's it.
Thanks, Luis. Let's go to Argentina again. Valvecchia, how is going?
And now the most entertaining part of the surgery begins. The previous was only preparations for this time. I tried to luxate the complex to anterior chamber with a spatula and microforceps. Well, anterior chamber, and now I cut the IOL with the scissors, but I don't cut the lens completely. I leave a hinge that will help me to extract it. Now with the same microforceps I pull out the IOL from to the eye, and I help me with the McPherson. It's a simple maneuver. Now I make a wide anterior vitrectomy in the place where the lens is going to be placed. With the 3D system, it's easy for the anterior segment surgeons to see everything. In the fundus, I'm not a retinal surgeon, but I learned to make a complete vitrectomy.
Thanks, Valvecchia. I can see here Mike is doing a Phacoshop. Let's see if Mike can listen us. Mikey?
Hey guys, as you can see, we're just starting to take apart the nucleus here. So I've done my central groove and crack, and now I do a little cross chop here. And now I do what I call horizontal phaco, so I just make a small little horizontal groove and use my instruments to crack it, as you can see there. So now I've got my quadrants, and I haven't had to rotate the nucleus at all. You can see how easy it just tumbles out, and we're able to remove this lens.
Let's go to Spain. Luis is ready to start to implant the CTR, the capsule tension ring. It's a case where it's a cell defoliation.
That's it. So we finished the phacoemulsification without a problem. Now everything is very clean, and I'm going to insert a CTR. We like to use CTR in all our premium lenses that we use here in the institute. And I'm finishing to placing the CTR in the back.
Thanks, Luis. I back to you in minutes. Ignacio is finishing his surgery. Ignacio, your final words. Thank you, my friends. It was a pleasure to be with you today here.
Okay, when we're coming to the end of the surgery, we have a very nice result with a center IOL with two haptics tacked on the scleral sides, 3 and 9 o'clock.
Let's see if Mike can listen us. Mikey?
And then I rotate the head about 30 degrees or so away from me, and then we'll rotate the microscope about 30 to 35 degrees away as well. I put a little dispersive viscoelastic on top of the cornea as a coupling agent, and then I use my gonio prism with the attachment on the eye as well. And then I just kind of gently rest my left hand on top of the cornea, not putting too much pressure or causing any extra striae. I'll zoom in a little bit here so you can see the trabecular meshwork a little bit better. And then you just kind of wiggle in your incision, make sure you don't get caught on the lip. You pull the sleeve back And now I'm just lining up, and I'll just a little gentle pressure here, and I deploy the first stent, come straight back, and then I'll move over a clock hour or so, get a nice good view of the trabecular meshwork, and deploy the second stent. Again, you need just a little gentle pressure. You want to go straight in and straight out so that the stents go straight in and straight out, and they don't have any tail on them. You can see they're sitting in a good position right in the trabecular meshwork. We've got a good view of the ostium here for you as well, and should get a good response from this. We'll rotate the head back and finish the case, take out the viscoelastic, and make sure everything's right where we want it to be.
Let's see what's happening in the Valvecchia surgery.
Just before inserting the IOL, I go to the triangle vertex, I rotate clockwise 30 degrees the needle, and I make the square tunnel. And now it's all prepared to, if that's possible, when the IOL was into the cartridge, I insert the first haptic. It's easy. Slowly, the IOL unfold into the eye. Okay, and with the microforceps 23G, I push the haptic. Now we insert the second haptic into the needle lumen. The only secret is to construct the main incision at 90 degrees from the incision of the scleral pockets. It's easy to put inside. We exteriorize the haptics one at a time. Slowly. And now we cauterize, we flange the haptic without touching. We create the first flange haptic. Now I am exteriorize needle, the second haptic. And cauterize. Okay, it's a little long out of the eye, but it's okay. Without touching. The first flange haptics is go into the scleral pocket. Now we only need to put the second flange.
Let's go to Spain again. I can see here in my screen, Luis is removing the Canabrava ring. Luis, everything okay with you?
Yeah, Sergio, I was waiting for you. Now you can see the panoptics very well centered, and I'm going to remove the Canabrava ring. I think once you pass the learning technique, it's very easy to remove it. I like to do it with Sinskey hook and with forceps. Remember that we inserted by 1.4 and now we are removing it by 2.2. You have to make like a curve movement, and it will be easier once you have it outside the eye. I think it's better to use a Sinskey por favor, and you take it out of the eye doing that curve maneuver that I was telling you. You can see that it's not difficult at all, and it leaves us a very nice and rounded pupil. I like to constrict the pupil a little bit, and we are finishing the case, and see you in a minute.
Let's go to United States. Mike, your final words. Thank you for this amazing session, my friend.
And You can't see the stents when you're looking straight down like this, but we know where we put them. You know, sort of at the 11 o'clock and 1 o'clock view here in the surgeon's view. You can see me pointing them out here and here. There's some nice episcleral vessels there, so we'll see if we get any blanching of the vessels, especially in that 11 o'clock region. So we'll go and remove some of the viscoelastic, and sure enough, you get a nice blanching of that upper left quadrant in our view here, where there were those 3 prominent blood vessels. Now you can only see the 1. And so again, just taking out all of the viscoelastic, making sure we get the IOL in good position, and then we'll finish the case. Again, just showing a little bit of the blanching here. As eye pressure comes back down, you can see that episcleral vessel fill back up, and as we hydrate our incision and the pressure inside the eye goes up, those 2 vessels go away. We're getting pretty close to normal tensive pressure here.
Let's go to Rio. Bruno, your final words, my friend.
Hi, that was the case. Old gentleman with a very shallow anterior chamber, high hyperopic. Hope you'll find it some interesting points for discussion, and hope you enjoy this wonderful meeting.
Thanks, Bruno. Valvecchia.
And in this case, we use the microscope with OCT, and you can see in the right down image the haptics perfectly into the scleral pocket and into the scleral. Probably it's impossible for the haptics to externalize, and my follow-up is 4 years with excellent results. And now, with the same microscope, we can see the tilt of the IOL. It's okay as well.
Thanks, Valvecchia. Luis, thank you to stay with us. Amazing case, your case. Your final words. I think everything okay, right?
So hello again, everything went very well. I want to highlight a couple of things. One, the possibility that gave us the Catalyst femtolaser, which allowed us to center the capsulorhexis in the apex of the lens, that I think is very important in premium IOLs. And also about the Canabrava ring, you saw that it has a very easy management and is very versatile, as I can use it in shallow ACs, as the case I have just done, and also in big ACs. I hope you liked it, and thank you very much.
Thanks. Amazing 5 surgeries today. 5 amazing surgeons. Thank you to be with us in this virtual live surgery. You recorded it before and you present for you today. But amazing, amazing case. Thank you. And let's go to discuss in live.
Thank you guys. It was really hard to do this session, but it's amazing. Luis is now here. Luis is a wedding now, and Ivo too. Dr. Sharma, the stage is yours.
So I think exciting surgeries, fantastic surgeons, and this is a session out of the box completely. Congratulations to Canabrava, Sergio, for envisaging this and doing it so well. So I have a question for Dr. Ignacio. You did a wonderful case of a subluxated IOL, and then you had planned a sutured IOL, but you shifted to a glued IOL. So yes. when you plan like this, when you shift from sutured to glued IOL, then what are the steps that you would change when you're actually shifting or converting from sutured to glued IOL?
Well, my plan was originally to do a glued IOL, but I didn't know what type of implant he had in his eye because it was 20 years ago and he didn't have any sticker or something. So I just wanted to open the pupil and then decide. So at the beginning, I thought it was a PMMA, so I started to suture it. But when I moved it upwards, then I saw the other haptic, which it was a 3-piece. So then I changed plan, and I rather did, so I did a glute, which is the technique that I'm most comfortable with.
Excellent. I think that was an excellent conversion. One more question. Sergio, do you have a question, or can I ask one more question to Ignacio? My question is that, do you need to, you very nicely, it went down and you picked it up and you carried on with the case, but what if it is just an anterior segment surgeon who doesn't have a vitreoretinal background? What message would you give it to that person?
In that case, you would have to work with a retinal surgeon near for the need to go and find the IOL in the back of the eye. I was with the complete set there, with the constellation and the vitreoretinal tools, so it wasn't a big issue. It was a little longer, the surgery, so we had to do the posterior vitrectomy and go to pick the IOL near the macula. It was very stressful, but fortunately it did well.
Ivo is our panelist today. If you have any question for the surgeons,
how are you, Sergio? First of all, congratulations for this amazing meeting. Then congratulations to the surgeons. I think every surgery left some knowledge behind. So I want to congratulate them, but especially because they were, I'm looking into the chat to see if people have questions, but I think they were very didactic. They teach so many concepts to the panel. So I'm going to leave it to that. And I don't know if people have any other questions about the technique. I'm going to search in the chat.
Sharma, the word is yours again.
Can I ask you a question, Sergio? Excellent, this thing of, Canabrava ring. I just want to ask you about this ring. You've made fenestrations into those, flanges of the Canabrava ring. So what is the advantage? Of course, it was very beautifully showed by Dr. Lewis, but what do you think? I mean, each of the flange has a fenestration. So if you had left it without a fenestration, what would be the, flip side or disadvantage?
Luis, you did the surgery. You have the word.
You are the expert in that. But I think it's very important to do what Sergio explains in all his videos, and each flange has to go into its position. If you don't put in the right position one of the flanges, then the Canabrava ring is not going to work as properly as if you do it if you put in the correct position. Is that correct, Sergio?
Yes. And you need to put the right side too, because the small parts need to be behind, and the large it's up, and the hooks need to be behind the iris. Then this position is so important.
I think, again, wonderful demonstration of how FLACS can be done in a small pupil with this ring. And that is one advantage, I think, which everybody needs to have. So when is, I don't think we have it in India. So when is it coming to, the Asia continent? We are looking forward to have it here.
Yes, we like it too. It's a very nice ring.
It is.
So, Mike, can I ask one question to Mike? Mike, lovely again demonstration of how you put the stents, the eye stents. Do you have you ever had to explant them? And if you do, is it as easy to implant? Is it more difficult to explant, or just, as easy to implant as you showed it?
thanks everybody for participating. And your first attempt is probably your best attempt. After that, they're so small that it can be a little bit hard to grab, but usually what happens is they just don't get inserted all the way, but they stay facing the correct orientation. And so the inserter has a little sharp point on it, and you're able to kind of put that in the small hole and re-thread it on the tip and just add a little bit more pressure and click the button again, and it should place it in. But they are the smallest thing that can go in a human, and so they are very, very small. And if they do get twisted around, it can be a little bit challenging. But the key is just take a deep breath, relax. Don't worry about your tremor or shaking, and just try and re-thread the needle, and then redeploy it.
Okay, I think that answers the question really very well.
Well, I have one question for Gerardo. Gerardo, in your surgery, what do you think are the key points or the key elements for another surgeon who wants to do your technique? Which are the key things he needs to master?
The steps, simple. Make the main incision at 90 degrees from the two scleral pockets. Take your time to do good scleral pocket, and take your time to do a scleral tunnel with the needle. With these three things, you make the success of the surgery. It's not a complicated surgery. I take the both. I copy Amaral, the pockets, and I copy Gingerman technique. I do a mix and I do the modification. It's simple to do, but in my opinion, it's safe in a lot of time follow up.
So it appears simple in your hands. It appears very simple in your hands, Geraldo.
No, it takes only the first 10 patients are difficult, then it's easy.
What about you, Bruno? What about you? What do you think are the key elements somebody who is starting needs to master?
The very first thing is to watch many surgeries. Today you have many available surgeries on YouTube and the web. So before trying, you must master the movements in the microscope and watch many surgeries. Even if you think it's a simple surgery, it can be complicated. Like the one I performed is a very shallow interchamber. This surgery should be done quickly. I just very afraid of positive vitreous pressure in these short eyes. So the surgery should last less than 8 minutes if possible, because otherwise you can go to this BSS, go behind the crystalline lens and make it positive pressure even a huge problem in these short eyes.
Bruno, and about your results with the eye hands, because a new IOL and it's come now, your first results.
I'm very happy with these results. I have blended more than 100 of these IOLs. It gives patients with binocular vision, intermediate vision of high quality. Near vision is not always very good. It's J4, J5. But you can plane minimum of vision with the dominant eye for plano and the non-dominant -1/2 or -3/4. And patients are very happy because you don't have this photic phenomenon like halos and glare, which you have with the diffractive technology.
Bruno, what do you think of FLACS in a case which has shallow anterior chamber and is hypermetrope? You think that is a better option?
That could be done. It's good. There are many papers that shows that FLACS is more safe when you have a corneal disease and shallow anterior chamber. If you have a combination of these two, this will be the best indication. I mean, low endothelial count and shallow anterior chamber, I think FLACS could be a good choice.
Luis, can you tell us about, you told me the CTR is a routine in your institute when you use a premium IOL. Can you discuss for us a little?
Sure. We always use the CTR in all premium IOLs, mainly because we think that it gives more stability to the back, and the centration of the lens is better. And also, although the percentage that premium IOLs needs to be exchanged is very, very low, but there are some, and with a CTR, the exchange of the IOL is much easier than if you don't use the CTR. So we are a private center, and for us that's very important, and this is why we use it in all our premium lenses.
Luis, you did mention that there is a learning curve to Canabrava ring. How many rings do you need to implant to be there?
2 or 3, it's enough. That was my second one. So I think 2 or 3, you are much more comfortable.
So I think that's a much shorter learning curve as compared to the other
Yeah.
that are available in
Exactly.
And as I say, is need to start in the easy case. Don't start in the challenge case.
Yeah.
Exactly. Maybe one good tip is not to use it in very small eyes with white to white less than 11, 11.2. What do you think, Sergio?
Yes, my suggestion is start to use in bigger than 11. Not only the Canabrava, but all small pupil rings. I don't suggest you using in small eyes. It's hard to perform it. I think the last comments for Mike, if you want to say your last comments, you have in our time. You have great news. Today, only in my YouTube channel, you receive more than 1,000 views, only during the events, and amazing numbers from around the world. And you, after the event, you send the numbers in the website. But thank you for these efforts. It's really was big. And Mike, your final words, and who want to say the final words too? Sharma, thank you again to be with us, and the word's yours.
Congratulations, everybody, on your live cases, and thanks so much for sharing them with us and the world. And I learned a ton on each of those cases, as was mentioned earlier. And congratulations, and enjoy your day, whatever you have left. I know there's a wedding. I have to get to a wedding, and everyone else is headed around for some other fun too. So congratulations, and enjoy the time.
So I think excellent. Thank you, Sergio, once again for conceiving this and doing this amazing and out of the box surgical session. And the way it was done, you had to be really on your toes, because it moved from one surgeon to the other, and then to the third, and then to the fourth and fifth, and back and forth. But I myself have learned so many things, amazing videos, very bold surgeries, and it gives confidence to other surgeons also to start these surgeries if they've not, already done so. So I think it was an excellent session.
Thank you, guys.
Thank you all. It was very nice.
Thank you. Bye.
Thank you.